Good morning. Hello, everyone, and welcome to our first virtual Pacific Northwest support group meeting for our ATTR patients. This is our first local meeting webinar, and we're excited to see more than 70 registrants. All our previous meetings can be viewed on the webinar section of our website, amyloidosissupport.org, and on our YouTube channel. This webinar should be available and up there in a few weeks. We hope to be able to resume some live meetings in 2022. We realize that the main thing lacking from these webinars is the patient-to-patient contact, but that is available in our Facebook groups. And we do have two ATTR Facebook groups, one for our wild type and one for our hereditary. There are questions you must answer to get in the groups. They are closed and they are private, and no one can see any posts that you make there unless they are members of the group. I'll put up links to that in the chat section. You won't be able to post comments in chat, but please do check it out, as there will be some links that are rather important posted there today. In the control room today, we have ASG's Executive Director, Paula Schmidt.
Hello, everyone. Glad you're here.
And our Special Projects Director, Bob Gibson.
Good morning, everybody.
We ask that you post questions in the Q&A section, and we will have our guest panelists answer them at the set-aside Q&A times. Our presenters today are Dr. Deirdre Mooney, cardiologist at Providence Sacred Heart in Spokane, Dr. Richard Cheng, cardiologist at the University of Washington, Dr. Jane Distad, neurologist at the University of Washington, Dr. Orly Moshe-Lilie, neurologist at OHSU, Dr. Ed Libby, hematologist at the University of Washington, Dr. Hongya Chen, cardiology pharmacist at OHSU, and last but not least, our host, Dr. Ahmad Masri, cardiologist at OHSU. This is really a who's who, isn't it, of Pacific Northwest amyloidologists, as we like to call them. There will be a short survey when this meeting is over, and we ask that you take the time to fill it out. It's really important, and it helps us in developing future webinars. And now, our host, Dr. Ahmad Masri, who will introduce today's presenters. Dr. Masri?
All right, fantastic. Thank you, Muriel. Thanks to our patients. Thanks for everyone who's taken this time on their Saturday to join us. I will be introducing the agenda here, trying to briefly go over this so that we can kick off the meeting. So, this was designed and meant to really address a lot of the common questions that come up in practice, and as well as that are relevant to patients, as well as to their family members and to other healthcare providers. And so we'll start the meeting off by discussing ATTR in the heart with Dr. Mooney. Then we will move to Dr. Cheng to discuss current treatments for wild-type ATTR. And then after that, ATTR in the nerves with Dr. Distad. And then one of my favorite talks, which is what do all these neurological tests mean? Dr. Moshe-Lilie will be talking about this. And then Dr. Libby will discuss what is MGUS and what did I undergo all these tests to rule out AL amyloidosis. Medication cost and insurance will be discussed by Dr. Chen, and then I will finish off by talking about some advances in ATTR therapies and future developments. And then we will have some questions and answers in between each of these talks, but we'll have the general discussion and Q&A by the end of it. And so without further ado, I'll turn it over to Dr. Mooney to kick us off here.
There we go. Okay. Hi, everyone. Thank you for the opportunity to come and speak with you. It is a delight to speak to such an informed audience. I'm here to talk specifically about transthyretin cardiac amyloid, or ATTR, in the heart. I'm coming to you from Eastern Washington, out in Spokane. Our big goal for today, we have three big ones. What does TTR cardiac amyloid present as? How do we diagnose it? how common is it, and what might it be masquerading as, leading to a later diagnosis or a missed diagnosis? We'll start first with symptoms. And right before we get to that, again, we are not talking about AL amyloid. There have been some really excellent webinars on this recently. So we're talking about TTR cardiac amyloid, which comes from the liver and the spinal cord process. It's in the tetramers, or as I recently heard someone call it, the 4-leaf shamrocks, where the leaves start to fall apart and stack up, causing those fibrils that get deposited in extracellularly between myocytes and other soft tissue structures. So eventually we can stop saying this, but it's historically been considered a rare fatal diagnosis, usually diagnosed in the late stage, usually diagnosed in older males, 70, 80-year-old or older. And at that point, it's a rapidly progressive disease, which is tragic, as it's usually presenting in end stage, despite that patients having seen multiple providers for symptoms related to it for months or years. And that's why this group and having such informed patients such as yourselves is so important to get the words out on the patient level. Historically, we were only treating it with heart and/or liver transplant or supportive care, but as you will hear in this exciting talk, that is changing. So some of the ATTR more specific symptoms, which can be a little different than AL, the arms can tell a lot 5 to 9 years before the onset of cardiac symptoms. You can see signs and symptoms of carpal tunnel, which can be numbness, or tingling, weakness, or even some loss of that muscles that we have in our hands. Patients might present with one side or both sides of their tendons rupturing. It might seem like it was provoked, they were doing weights, but often it's the rupture is out of proportion to the activity that they were doing. Some shortness of breath, palpitations, chest pain or fatigue. These are also considered heart failure symptoms, also considered deconditioning. So I think all of us are about to go through some of those symptoms as we put on lighter clothes and dare to leave our house as the cold weather leaves us and the COVID pandemic lightens. Very common to see low back pain and even low back pain with pretty objective findings like spinal stenosis. A large majority of people will try to undergo therapies for low back pain. And then it often will start as a progressive peripheral neuropathy. So starting in the distal feet, numbness, burning, tingling, some weakness, and then it can go to the upper hands. So the feet might be the first sign. And then the swelling of the legs is much more speaking to the heart failure symptom. And the gut, as we know, there's a huge connection between the gut and the brain, or neurologic connections. And so with all that nerve distribution, we see a significant impact. So you can see the heart failure or the neurologic impact there with kind of like a slow transit time, constipation. Sometimes you can get diarrhea later. There can be bloating or excessive gas, as well as a poor appetite, or maybe a normal appetite, but then early filling, or what we call early satiety. So again, these are some of the classic things that you might find yourself saying: I can't catch my breath, or I just can't do the activities I used to do. I can't shovel as much. I can't walk as far. I'm pausing when I get to the mailbox. It takes longer to recover. If I do one thing or a busy day, it takes another day to recover. The swelling in the belly, the swelling in the legs. And then some pretty important ones are things like syncope, or passing out, or almost passing out. And the classic example is getting up from a position, either lying down or sitting, and about 5 to 10 steps from where you were, starting to feel dizzy, lightheaded, the shade coming down. And that can be a sign that your heart and your blood vessels and your nerves are struggling to keep up with that activity change. Maybe the blood is pooling, your blood pressure is dropping. And that's because the compensatory mechanisms that all of us naturally have when we're younger and our body is not affected by things like this are having trouble keeping up. And some of that can be exacerbated by some of the medications that historically we did need. If we had high blood pressure, we might be on something that can lower the peripheral blood pressure. If we were having fast heart rates, we might be on a heart rate slowing medicine. And so another sign of amyloid can be all of a sudden your blood pressure is better controlled. And while we would love to take credit for that, it's usually like out of control. It's improved control out of proportion to the things we've been doing. I believe someone's speaking about the electrical process later, but I did want to say that it can present in almost any way. Atrial fibrillation, where you have a disorganized heartbeat, increased clots in the little crevices around the heart, that you can get conduction disease, the top and the bottom have trouble communicating, or it takes a lot longer for transit, or then paradoxically, despite having the risk for slow conduction, the bottom of the heart can suddenly start sending some pretty fast rhythms, and those can be quite dangerous, ventricular arrhythmias. And so there is a role for pacemakers and defibrillators that can be discussed later. And as we briefly talked about, carpal tunnel syndrome, it's the most frequent peripheral neuropathy in the general population, estimated around 3 to 4%. The carpal tunnel release is one of the most common upper extremity surgical procedures, and the lifetime prevalence is about 3% for people in the United States. When they did an Italian cohort of patients with cardiac ATTR, they found 20% of them had carpal tunnel interventions versus 4% of a general population. This is a very important clinical marker. It can precede the diagnosis of cardiac amyloid by 5 to 9 years. And now that we're talking about therapies besides something as dramatic as heart transplant or hospice, we're talking about pills, subcutaneous injections. This is something where if we can catch this diagnosis before we have as much damage, we are in a great place. And it can also impart some prognostic information. Again, having one diagnosis or not will change your prognosis. AL has some pretty classic skin findings. With ATTR amyloid, it's a little bit less classic, but over here we have a picture of these little red dots, which are called petechiae, and amyloid distributes throughout the body. And so there can be end deposition not only in nerves, but in small capillary beds or the tiniest little blood vessels in our body. And those create what's called fragility. And so simple skin trauma can cause it. You'll often see it on their hands, their forearms, things that keep butting up against things, doors, keys, or chronic sun damage will exacerbate that. Some atrophy scars and some persistent ulcers or hard to heal skin lesions. So moving on to the diagnosis. Thick hearts. So what we're looking at right here is 2 very thick hearts. On the top left, we can see part of the right side of the heart. Then the bottom chamber is the left side, very thick walls. That's at least twice the normal thickness. And then we see that on the right side. What we also see is a little bit of black area surrounding the heart, and that's a pericardial effusion. And then we see pleural effusions at the very bottom in that black area. All of those are very classic findings in cardiac amyloid. And what makes this stand out from some of the other causes of thick hearts like hypertension is that the right side of the heart and the atria are also thickened. Now, when we see thick hearts, we expect that to be hypertrophy, and we expect really large voltage or really big dynamic EKG findings, and we're not seeing that on here. So this is increased wall thickness without the associated hypertrophy ECG changes, and that's another disconnect that can be a sign that this is amyloid, because it's not the actual cells that are getting hypertrophied. There is stuff between the cells, so the effective area is still large. There is an apical sparing appearance on the echo. And so on the left, we have global longitudinal strain, or that cherry on top, where you get the movement tracks best at the apex. And then here on the right is how we calculate an ejection fraction, where we take a picture when the heart is maximally filled and a picture when it's ejected, and we measure the volumes. And you can see that at the very top of your screen, which is the distal portion of the heart, it really came together the most. And that is suggestive that the apex is moving more. Now, there's theories about that. Is it related to where the nerves go? Because the nerves appear to be strongest at the base of the heart, which is most affected. Or is it because the apex is so thin that there's just less tissue? And then with less tissue, even if you have homogeneous distribution of amyloid, there's going to be less amyloid at the apex, and therefore it's just not going to slow as much. And then over here, we have some fancier and fancier markers. Now, these all depend on how good your imager is and how good your imaging pictures can be. But impaired relaxation, fast filling or deceleration time indicates like a very stiff heart. And then, so we have a the diastolic dysfunction. We have tissue Doppler on the left, and there's a marker there that's less than 6, which is kind of a very classic finding. And then on the right, we have the pulmonary vein flow, which is, our right side pumps to the lungs, and then the lungs drain into the left side. And so we'd like it to have all the time in the world to easily fill and not have a high pressure system, but this is evidence of a high pressure system. Cardiac MRI, very long, complicated test. And what we have here is diffuse late gadolinium enhancement in the left ventricle. And we can see that lighting up there. So this is gadolinium, which goes into the extracellular space. And since there is so much more extracellular space with those amyloid fibrils, it gets stuck in there and can take quite a long time to wash out. Whereas over here, you see pristine black myocardium, and it's able to be, you can see a clear difference that it's thinner and that it doesn't have that gadolinium stuck in there. Interestingly, the gadolinium is also getting stuck in the atrial walls. That's the back chambers of the heart, which are usually very thin. And so very, very thin and without that extracellular space, but we see it here, and that's a very classic finding for amyloid. This is another imaging modality, and I almost said newer, and I'll just say newer in how we're using it for cardiac amyloid, but it's a very old, simple technology, a bone scintigraphy, which largely been replaced by a lot of other like PET scanning and cardiac MRI, but it still has a role for inflammation and scar. And so over here, what we see is they inject a radiotracer, a nuclear isotope, and they take a picture at baseline. And then somewhere between 1 to 3 hours later, they take what's called a region of interest. And that is in circle 1 and circle 2, where they compare how much uptake we get. And if you get a lot more uptake in the heart region, that's considered positive. Greater than 2 is considered wildly positive. And here's our, if there's no uptake, it's negative. If there's uptake less than rib, it's still negative. If you have it as much as a bone, then your heart is taking up a lot of radiotracer, which is abnormal. And these are pictures of the scale. And you can see on the bottom is a SPECT CT scanner to let us know, is it the bone that we're picking up? Is there something else? And it just helps us distinguish between that and inflammation. And you can see at the top the hints of the heart picking up. So 3 is very abnormal and 0 is normal. Echo can tell us it's a thick heart, suggest amyloid. It's not diagnostic, and it can't tell the difference between AL and ATTR. So on the left, we have an AL amyloid patient, and their heart is not lighting up. Now you can sometimes get a little bit like a 1.5 or a 1.8, but you seldom ever get greater than 2. I've only seen it once. Whereas on the right, it's an ATTR. And so this is a way without tissue biopsy that can suggest it's AL. Again, you should always be looking for AL in other ways. The sine qua non, what we've used the longest is the cardiac biopsy. We can go in through the veins in the groin or the neck with a tiny thing we call a bioptome and take a piece of the heart. It killed me because I love to leave our heart intact, but we do it in our heart transplant patients, and we do it when we need to know what's going on because it's going to change our management. And we take these little multi-millimeter biopsy samples. We give them to our wonderful pathologist. And if we get this back, that is great. This is normal myocardium. There's a lot of pink cells. They're touching each other. They're not too big. They're not scarred. This is not as pretty. There's a lot of stuff in between these cells. This is amorphous, fibrillar, proteinaceous material. Think of it as like tinsel surrounding everything, making it hard for them to interact, to communicate. Our cells like to communicate and work together, conduct signals. So side by side, you can see a lot more spacing out, disconnect. The tissue just doesn't look as healthy. We can do another stain called Congo red. And this allows us to see these apple green biorefringence, which is very specific for amyloid. And then when you send these biopsies to certain places like the Mayo, they have technology to do extra staining or to do liquid chromatography, tandem mass spectrometry to look for them and then test out with PCR and figure out, is this a TTR variant? And they can give us which gene it is. Is it a different type of amyloid, one of the 5% that is much less common? Or is it a kappa or lambda light chain? So to wrap up, we have prevalence and clinical mimics. So when patients present with those signs, we said are heart failure signs, shortness of breath, fatigue, edema, changes in their vital signs, and they're holding onto fluid in their legs or their belly, we call that heart failure. Whether it's a stiff pump or a weak pump, when you're holding on to fluid and the heart's the reason, we call it heart failure. And we look at, do they have a thick wall or a not thick wall? When they have a thick wall, we have to rule out, is this just good old fashioned high blood pressure, low oxygen issues that have been going on for a long time and the heart's appropriately thick? Is there a genetic thing from hypertrophic cardiomyopathy, one of the most common genetic mutations affecting the heart? Or is it something that's infiltrated the heart and causing disease like amyloid? Because there are other ones that can infiltrate the heart, like Fabry's and storage disorders. So in what we thought was a hypertrophic cardiomyopathy panel, when they sequenced everyone's genes, about 1% of people in a British population had positive genes. So they could have both, or they might be getting mislabeled as hypertrophic cardiomyopathy and actually have hereditary amyloid. And then they did a sample of almost 300 patients in a French cardiology clinic, and they sequenced everyone's genes, and they found 6%, almost 6% were gene positive. And 88% of those who were gene positive upon discussing had those heart failure symptoms and met the criteria for familial amyloid cardiomyopathy. 12% did not have any symptoms at that time. And if you look at the difference, a 10-fold difference, where of those who were gene positive, 46% had undergone carpal tunnel surgery versus 4% of those who were gene negative. 53% reported neuropathy versus 4%. And almost half of them had a reduced ejection fraction versus just 14% in the general population. So how do we diagnose this? You have to be suspicious. You have to confirm your suspicions. You subtype it to find out if it's AL, TTR, or something else, and then you treat or refer. So at the top of this one, we have clinical or echo findings. Then we have a blood and urine test to rule out AL. That is a diagnostic imperative to make sure we're not missing time on this aggressive disease. We look to see if that's abnormal. If it is, we absolutely get our oncologist and often a surgeon involved to get a fat pad biopsy or aspirate, so we're not losing time as we get our bone marrow biopsy. If we're not seeing anything abnormal to make us think about AL, then the next step I recommend in line with this Mayo Clinic protocol is to move on with the PYP. If they did not have a cardiac MRI, I don't do it. It doesn't help me if I really think it's amyloid, but it might have been done ahead of time because I was wondering what is going on and gathering more information to determine my level of suspicion. If your bone scintigraphy or your PYP scan is very positive, I send off a DNA sequencing to determine wild type versus hereditary and start treatment in line with those therapies. If it's between 1.5 and 2, I might move on to a biopsy. And so these are some of the mimics. We are seeing 6% of the patients 65 or older referred to get their aortic valve replaced. 6% of them have evidence of cardiac amyloid on the tissue biopsy. And then for those being referred for the transcatheter, so going through the leg or other areas that is non-surgical, 13 to 16% of them will screen positive if you do one of those bone scintigraphy scans. And they definitely have an increased risk of complications. Again, we talked about easy bruising, bleeding, some difficulty with blood pressure and heart rate issues. But regardless of whether or not they have the diagnosis, it is reassuring that intervening with a transcatheter aortic valve does seem to improve their outcomes. And this below here is a picture of this balloon inflatable valve that can be delivered without having a sternotomy. Important questions remain whether or not there's a causative link between aortic stenosis and ATTR cardiac, and how the existence of these affects outcomes. So again, ATTR cardiac amyloid, it's hiding in plain sight. It's up to 16% of patients already seeing cardiologists, and we just need to be more suspicious and looking for it. Remember, it's underappreciated. It is not rare. It's critical to recognize it early. Effective treatments do exist. And I don't have to tell you guys to be your own MD. So I'd like to hand the screen back over and listen to some questions now or answer them later. Thank you guys for your time. It's been a delight talking with you.
Thank you so much, Dr. Mooney. We only have time for one question here. And we'll like to bring in all of our cardiologists on this. Okay, well, we have 3 all, right? Walt asks, when you have heart blocks, how does your heart signaling work? What about if you have multiple blocks? And I'm going to throw in a question here. What is a heart block? So there you go. And we're kind of short for time, so let's kind of keep this to a limit, okay? Thank you.
We have multiple signal points in our heart, the sinus node, the AV node, and then the bundle branches, which take the train of our signal down through the heart. And so if cell-to-cell communication is impaired because of all that amyloid deposition, the signal can get stopped, diminished, or take a long time. And so sometimes we call heart block, which is really just a decreased conduction or slowed conduction delay, and it might actually be better to call it conduction delay, but sometimes it's a true block and the top and the bottom are not talking. That sounds devastating that the top of your heart stopped telling the bottom to beat, but the bottom has its own intrinsic system and will beat, but it is usually quite slow. Pacemakers and defibrillators still work in this population. They seem to be as efficacious. There's been people looking at them to see, because obviously this tissue is different than normal healthy tissue. But a heart block is usually something wrong with the conduction. It's not always as simple as an actual blockage or a mechanical obstruction, but there is mechanical obstruction slowing the way. You can picture driving on a road versus driving on sand. It might just take longer to make your transit because the terrain is different.
Thank you so much. Dr. Masri, you want to take it away?
Fantastic. Thank you, Dr. Mooney. Thank you, Muriel. Next, we'll move to a talk by Dr. Cheng, who's a cardiologist at the University of Washington and an amyloid specialist. He will be discussing treatments for TTR cardiomyopathy.
Good morning, everyone, and thank you for joining us. Thank you, Dr. Masri, for that kind introduction. So I'm one of the heart failure cardiologists at the University of Washington, and I have the privilege to give you this talk on the treatment for TTR cardiomyopathy. So I was asked to cover this topic in about 10 minutes. So I'm going to go relatively fast, and I'll take any questions at the end of this. So when I think about TTR cardiomyopathy, there's a number of different things that can happen that we have to treat. The first thing that's very important is we want to treat the heart failure symptoms. In addition, as Dr. Mooney alluded to earlier, arrhythmias are very common. So it's very important that we focus and treat these appropriately. The next thing that we look at is we really want to look at focused treatments to treat the underlying disease process. In this case, this is the production of TTR and the misfolding of this into amyloid. And for patients with advanced disease, then we consider advanced therapies. I think this is a very complicated field. And I put this quote here because I feel like this sums up the field nicely. So there are known knowns. There are things we know that we know. There are known unknowns. That is to say, there are things we know we don't know. But there are also unknown unknowns. There are things we don't know. But in the case of this talk, I'm going to try to focus on the known knowns and the known unknowns. So from a traditional heart failure therapy standpoint, what can we do? So many different things cause heart failure, and many patients with amyloid will present with fluid overload. The mainstay of therapy is really to keep that fluid off and to maintain an optimal fluid balance. The problem in cases of amyloid with TTR is essentially with the amyloid deposition. It makes the heart very stiff. So normally the heart expands, contracts nicely, but when you deposit amyloid there, it thickens the walls. And because of that, the heart's very thick and the cavity is very small. So you develop what we call restrictive LV filling, where it's very difficult to fill the heart. And as you try to fill this, the fluid backs up into the lungs and the rest of the body and makes you short of breath. In addition to that, because of the small LV cavity, each time the heart beats, there's a very low stroke volume. It pushes out a small amount of blood. To combat this, we often use loop diuretics. Many of you are familiar with Lasix or furosemide because this can help keep the fluid off. However, the bioavailability of this is not great, and we often will switch patients to either torsemide or bumetanide, otherwise known as Bumix, because these are better absorbed. One thing to keep in mind about cardiac amyloid is because of the restrictive filling, you have to balance the preload. In other words, you have to keep the cavity full, because if you don't keep the cavity full, you can't really push the blood forward. These loop diuretics will also cause loss of potassium. For this reason, we'll often also institute aldosterone antagonists with spironolactone or eplerenone to make sure that you don't lose potassium. For patients where the volume status is very challenging, we've found that implanting a CardioMEMS device is very useful. What this is this is an implantable sensor This is a percutaneous procedure, so it's not a major surgery. This goes through the vein all the way to the lungs and it sits there and it monitors the pressures continuously. The nice thing for this is we get a reading of how much fluid you're holding because it gives us a pressure reading from your lungs day to day. And from this regard, we can titrate your diuretics between clinic visits. What about standard heart failure therapies? This is in regards to both those with normal ejection fraction, so normal pump function, in addition to those with low ejection fraction, because with TTR amyloid, it can present as either, and it sort of encompasses the full spectrum. For ACE inhibitors or ARBs, which are commonly used in heart failure, these tend to be relatively well tolerated, but we do recommend watching for hypotension or low blood pressure because patients with amyloid often are more susceptible because they tend to vasodilate more than other patients. Beta blockers, which are a mainstay of therapy in cardiology, tend to be poorly tolerated because of the low stroke volume from the small LV cavity. If you beta block patients, it decreases the heart rate and decreases the forward flow. Even though these can be useful, we tend to use them at low doses and we monitor very closely. As Dr. Mooney was saying earlier, arrhythmias are very, very common in cardiac amyloid. So this is actually a slide I borrowed from Mayo Clinic. But on the left here, this is the normal conduction system. So normally the impulse starts at the sinus node, it conducts down through your AV node and then into your ventricles, and it essentially depolarizes your left ventricle and your right ventricle. The problem most commonly that we see in patients with cardiac amyloid is that we see atrial fibrillation. Because amyloid deposits everywhere in the heart, the atrial chambers, the ventricular chambers, pretty much every cavity, it causes irritation. And when there's irritation, these atria fire spontaneously very, very fast, kind of everywhere. And what ends up happening is that these cavities fibrillate. The actual prevalence of atrial fibrillation is a little bit variable depending on which study you look at, but it's been reported as high as 70% of patients with wild type TTR. The one thing to keep in mind in patients with amyloid and atrial fibrillation is you really have to anticoagulate all patients, because what ends up happening with atrial fibrillation, you get stasis of blood, essentially blood pools in the left atrium and the right atrium, and you can form clots. There's actually data from Dr. Maz Hanna's group at Cleveland Clinic looking at this, and they showed that traditional risk scores such as a CHA2-VASc. So this is a risk score that we use to really tell patients, are you at high risk for forming clot or not? This does not apply to patients with amyloid. So if you have amyloid and atrial fibrillation, you need to be on a blood thinner regardless of your CHA2-VASc score. What about left atrial appendage closure? So there's a device called Watchman that we can implant that essentially closes off the extra areas of the left atrium to prevent clot formation. There's actually very little data on this in amyloid patients. So in talking to my colleagues, I had a discussion with Dr. Grogan about this recently. We recommend this only for patients with contraindications to anticoagulation because it's just not well studied in patients with cardiac amyloid. Digoxin is another agent we sometimes use for rate control for patients who go very fast in atrial fibrillation. I think the challenge with this is historically there were concerns it binds to amyloid fibrils, which can increase your risk for toxicity from the drug. More recent data, again from Mayo Clinic, has shown that this may be safe. This was studied in patients with light chain amyloid. But I would say that if you use this in TTR amyloid, this needs to be monitored very closely. For patients with refractory arrhythmias, we tend to use a drug called amiodarone, which prevents all types of arrhythmias, and this tends to be relatively well tolerated. This was another study from Mayo Clinic where they looked at 58 patients with cardiac amyloid who had atrial arrhythmias who were referred for cardioversion. So this is when you shock a patient to get them out of their arrhythmia. In this series, it included 29 patients with TTR amyloid and 29 with light chain amyloid. All these patients underwent a procedure called transesophageal echo, where we put a probe in the mouth and we essentially take a picture of the heart to make sure there's no clot in the heart before you shock the patient. Because if there is clot, it can lead to a stroke. What we see here in blue, these are patients with amyloid. Red are patients who do not have amyloid. And what you see is there's a high cancellation rate in patients with amyloid. Because it turns out that in these patients, 13 of the 58 had thrombus. This includes patients who were only in atrial fibrillation for less than 48 hours, as well as 4 patients who were actually anticoagulated for more than 3 weeks. This is actually a really important point because normally when patients are on AFib for short duration or anticoagulated, we usually do not do a transesophageal echocardiogram. However, in amyloid patients, the risk for clot formation is so high, we recommend doing a transesophageal echocardiogram before cardioversion, regardless of whether you're on anticoagulation or not. The other thing to keep in mind is that even though risk of clot is higher, at least in this study, the success rate of cardioversion in terms of getting people out of atrial fibrillation is the same, regardless of whether you have amyloid or not. Although other studies have shown that long-term outcomes, patients with cardiac amyloid are more likely to have recurrent AFib down the line. What about the role of pacemakers and defibrillators? Dr. Mooney also touched on this earlier. In general, we only recommend defibrillators, otherwise known as ICDs. So these are devices that you implant and they sit in the heart and they monitor and they'll treat you if you have arrhythmias. We only recommend it for patients with a history of sudden death or ventricular arrhythmias. In cardiac amyloid patients, the benefit for primary prevention of defibrillators is not clear. There have been some retrospective series looking at this. Basically, there were observational cohorts and they were not trials. But what they saw is even in patients who received appropriate therapies, so patients, for example, they get these implanted and they end up having some type of arrhythmia, they get treated, there was no survival benefit. So it's a little bit unclear whether we should be implanting these for primary prevention in cardiac amyloid patients. What about pacemakers? So oftentimes with cardiac amyloid, again, it deposits everywhere in the heart. This can lead to fibrosis in the conduction system. And if you get substantial fibrosis, this would impair the conduction. And because of that, patients develop heart block. And when that happens, we would recommend a pacemaker. Normally, when we pace a patient, you put a single lead into the right ventricle and pace the right side of the heart. The problem here is the right side comes in first and the left side comes in. Essentially, the heart becomes desynchronous. So there's some data showing that in patients with cardiac amyloid who need pacing, who do have a relatively wide QRS or a conduction abnormality, you should really consider something called CRT, cardiac resynchronization. So in this case, you put a lead that paces the right as well as the left side of the heart. And it's been shown that this is effective in patients with cardiac amyloid. I'm going to move on now and talk about targeted therapies. So many of you are familiar with this slide. This is a diagram from Rick Ruberg at Boston University that essentially shows what happens in the process of TTR amyloid. As we all know, TTR is made in the liver. This is a TTR tetramer, and then it basically dissociates, forms dimers, and it dissociates further into monomers. This misfolds and forms amyloid, and these amyloid deposits in various organs such as the heart, oftentimes in nerves also. So what drugs do we have to treat this? We have drugs that are able to knock down TTR production on the level of the liver. This includes participant and inotersen. I'm not going to talk much about this because in the US, this is only FDA approved for hereditary TTR neuropathy, and Dr. Distad will talk about this next. For stabilization in terms of what we can give patients to essentially prevent dissociation of this tetramer, what's currently FDA approved is tafamidis, otherwise known as Vyndamax or Vyndaqel. Essentially what this does is this binds the tetramer and prevents this from dissociating, and because of that, you cannot go on to form amyloid fibrils. You'll often hear about diflunisal. So this is a non-steroidal anti-inflammatory, which historically has been used as a pain medication. There's some data showing that this is also a TTR tetramer stabilizer. However, it's less selective than tafamidis. We would sometimes use diflunisal as a prophylactic drug in patients who have a genetic, who carry one of the genotypes for TTR amyloid, so have a genetic change, but they don't yet have clinical findings. So we think this may slow progression to clinical disease. But in patients with clinical disease, we tend to use tafamidis because most of the data is with tafamidis. AG10 is another TTR stabilizer. At least in vitro, this has higher kinetic stability. What I mean by that is it binds more tightly to TTR tetramer. The study has finished enrollment, and we're currently in the follow-up phase for AG10. There's been a lot of interest. What can you do to remove amyloid? So for example, you already have amyloid in the heart, can you remove it? So there's been some data with doxycycline and TUDCA. The data for us is actually not that good, so we don't use it that frequently because it's unclear how effective this is. This can also lead to many side effects, such as stomach side effects, or patients can get sun sensitivity. PRX004 is currently in phase 1. This is an antibody that binds to amyloid fibrils and will remove it. I'm going to focus a little bit more specifically on tafamidis, since this is the only FDA-approved drug for TTR cardiomyopathy. So many of you are familiar with the study, the TRACK study. This is data from Matt Maurer, published in the New England Journal of Medicine, but this is a subgroup analysis. And what you see is that we know that tafamidis is very effective in reducing mortality and heart failure hospitalizations. When you look at subgroups, so these are specific groups, whether you stratify this by hereditary TTR versus wild-type TTR, functional status, so class 1 or 2, patients with no symptoms or mild symptoms, or patients with more advanced symptoms, or depending on the dose in the study, they randomized patients to 20 milligrams, 80 milligrams versus placebo. The findings were consistent. Tafamidis is beneficial regardless of subgroup. When you look specifically at heart failure hospitalization, similarly, it decreased hospitalization across most groups, but there was not as much benefit in patients who are NYHA functional class 3. So these are patients who are more symptomatic. This goes back to argument that you want to make an early diagnosis, because if you treat them early, they're more likely to do better long-term. You really want to institute tafamidis as early as possible to prevent progression of disease. So this is a slide from 2019, but still holds currently in March 2021. What treatments do we have that are currently available and FDA approved to treat TTR amyloid? So for a wild-type TTR cardiomyopathy, we have tafamidis and diflunisal. For hereditary TTR, if you only have cardiomyopathy, we have tafamidis and diflunisal, so it's the same. However, if you have neuropathy, then you can consider patisiran or inotersen in addition to tafamidis and diflunisal. And again, Dr. Distad will talk more about this in the next talk. I'm going to talk a little bit about ongoing clinical trials in TTR cardiomyopathy, just so you're aware of what the current studies are. So there's a lot of interest in looking at knockdown and silencing agents for TTR cardiomyopathy. Even though patisiran and inotersen are currently approved, they're only approved for neuropathy, but these ongoing studies are looking at these agents for cardiomyopathy. So there's the Apollo B study with patisiran and Helios B with vutrisiran. So the difference is vutrisiran is a second generation GalNAc agent, which is more targeted. These two agents are from Alnylam, and they're currently enrolling in patients for TTR cardiomyopathy. CardioTransform is a study from Ionis Axia. This is a little bit different. Instead of this being an RNA silencer, this is an antisense oligonucleotide. Effectively, it does the same thing, where it knocks down TTR production. This is also very targeted, and this study is also has ongoing enrollments. So these drugs directly act upstream of tafamidis. Instead of stabilizing TTR, or knock down production of TTR. There's also ongoing studies looking at amyloid extraction and degradation. So again, what happens after you redeposit amyloid? I mentioned earlier, PRX004 is an ongoing study which recently completed phase 1. It's unclear what the next steps are going to be with this. There is an antibody called NI006, which is currently in phase 1. So this is a recombinant IgG1 human monoclonal antibody that binds to amyloid and may remove it. There was another antibody called anti-serum amyloid P, which was actually being studied, but because there's no benefit in phase 2, it's no longer in production. Additionally, you're going to hear a lot about inhibition of amyloid seeding. So what is amyloid seeding? So if you have preformed amyloid fibrils, what can happen is native TTR can actually bind to these native fibrils and propagate amyloid formation. So there's a lot of interest in developing inhibitors such as TAB-FX2. What this does is it prevents fibril aggregation, and by doing so, it prevents seeding, and it prevents propagation of amyloid. I'm going to end by talking a little about advanced therapies for TTR amyloid. So for patients who have very advanced disease, we can consider LVAD or heart transplants. This is a study from Josh Gogan's group, but what they looked at is they looked at INTERMAX, which is a cohort of patients who undergo LVAD. In this series, there are 46 cases of cardiac amyloid. This was not specific to amyloid subtypes. It includes light chain, wild type, and hereditary TTR amyloid. In general, the LV dimensions are very small. What they found, this is the black line here, and down here, these are patients without amyloid, but patients with amyloid, they had a higher risk, so this line is higher for mortality than patients without amyloid. So LVADs may not be the best option in patients with amyloid because there's an increased risk for mortality. So in general, at least at University of Washington, we avoid placing LVADs in amyloid patients because we know the outcomes are not great. What about heart transplants? So again, this is a relatively extreme measure, but this can be a life-saving therapy for those with advanced disease. This is data from UNOS, which is the US governing organization for heart transplants. So this looked at their data of 108 patients, again, with any amyloid, not stratified, to compare an older era to a more contemporary era. And what they showed is in the old era, amyloid patients did worse. So these are survival curves. So the lower, the worse they do. So amyloid patients did worse than non-amyloid patients in the earlier era. But in the current era, amyloid patients do fine. This was not significantly different, and we think this is due to patient selection. So in other words, heart transplant can be a life-saving therapy for patients with cardiac amyloid. So in summary, the take-home points, data on traditional heart failure therapies are lacking. In general, we recommend diuretics, but it's unclear whether other therapies such as beta blockers and ACE inhibitors have any benefit. There's actually no good data on this. In terms of FDA-approved treatments for TTR cardiomyopathy, currently we still only have tafamidis, although there are many trials underway, which I showed you earlier. There is a very strong indication for anticoagulation in patients with TTR cardiomyopathy with AFib, regardless of any risk score, you should be anticoagulated. And heart transplant is certainly a viable option in those with advanced cases. I thank you very much for your attention. I'm going to leave the slide here, which summarizes sort of the pathway in terms of treatments. Thank you very much for your attention.
Thank you so much, Dr. Cheng. That was kind of everything you want to know about treatments, but we're afraid to ask. But there are questions, but we don't have time to do them right now. We're going to wait till the end of the program, and then we're going to hit everyone up with the questions. And we want to remind everyone that eventually this program will be up on our website and on our YouTube channel. So now, Dr. Masri, we'll ask you to take it away. You're on mute right now. There you go.
Right, fantastic. Thank you, Dr. Cheng. This was great. Finally moving from the heart. It's been an hour on cardiac issues. Now we're moving to ATTR in the nerves with Dr. Distad. So Dr. Distad is a neurologist at the University of Washington, and she will talk to us about ATTR in the nerves.
So thank you, Dr. Masri, for the introduction. Thank you for Muriel for guiding us. And Dr. Masri, especially, thank you for putting this all together. Hello, everybody. So excited that you're out there today. I'm going to talk about the amyloid transthyretin amyloidosis in the nerves, reviewing symptoms, diagnosis, and treatment for hereditary ATTR. We know transthyretin is the plasma transport protein, and it becomes misfolded related to the mutations that cause this dissociation. It ultimately forms insoluble amyloid fibrils that deposit in organs and specifically for my topic, in the nerves. The amyloid ATTR will deposit in the peripheral nerves, the autonomic nerves as well. And this leads to neuropathy. And for example, up to 70 and 90% of the patients with the common Val30 MET mutation will have neuropathy by the ages of 80 to 90. And the symptoms can occur related to amyloid deposition within the blood vessel from compression or damage within the nerve itself. And on this slide, this is a cross section of a nerve biopsy. And this is the nerve. These are the nerve fibrils. And you can see these gatherings of things that look like they probably aren't supposed to be there. And that's the amyloid that we're seeing. So you can see how it can disrupt normal nerve function. This is a example of the amyloid in the nerves, in the blood vessel along the nerve. So this is also a biopsy. And the pink is the amyloid, and we can see it deposited within the blood vessel wall here. And when polarized light is added to it, that's when we get this apple green birefringence that is classic for amyloid. Symptoms in the nervous system will vary depending on the type of mutation, the clinical disease stage, and from person to person. The most common presentation is sensory, and that's numbness and tingling. And the earlier symptoms will be pain and temperature sensation affected first in the classic form, and then light touch and position sense. And position sense is knowing where your body parts are in space, and that's conveyed by the peripheral nerves. A compressive neuropathy, as Dr. Mooney has brought up, is an important signal of potentially progression of that amyloidosis to other areas, and that's manifested in carpal tunnel syndrome, which is seen in about 30 to 40% of patients with amyloid. The balance difficulties are evident when people are walking mostly, and weakness occurs similar to the areas that are affected by the similar to the areas where we also see sensory involvement. And so that would be the feet and then the hands. Autonomic nervous system is also involved. And the autonomic is your automatic nervous system. So it controls many things, but the heart, the gut, the GI system, also sexual function, and symptoms that can occur we call most commonly orthostatic hypotension. That's lightheadedness with standing up. The gastrointestinal involvement is early satiety, so feeling full even with just small amounts of food. And constipation alternating with diarrhea can occur, leading to unintentional weight loss. And lastly, mention also sexual dysfunction that can occur when amyloid affects the autonomic nervous system. Diagnosis is based on clinical history of symptoms that go along with neuropathy, and then an examination documenting areas of abnormality that we will see in neuropathy, but not necessarily specific to amyloid. Nerve conduction studies and EMG are helpful to evaluate involvement in the nerve. Laboratory tests are important to exclude other causes of neuropathy because neuropathy is common in the general population. Genetic studies through the blood or saliva will be able to confirm a mutation in the ATTR. And a nerve biopsy can identify the evidence of the amyloid within the nerve itself. Most commonly, the sural nerve in the leg is tested. However, it can be patchy, so we have to be very cognizant about what we're using to make the diagnosis and what areas we're testing. And then there's a panel of autonomic testing that can evaluate what areas of the autonomic system are involved. The examination will follow similar to the symptoms. So if there's weakness, it's going to be in the lower legs. That would be raising up the toes and the foot. Reflexes are decreased, again, more so in the legs, so at the ankles most commonly early on. And then with sensory loss, all see decreased sensation to pin and to cold sensation in the feet, and it may involve the hands, and that may extend up the leg. And then also testing light touch, vibration sense, and joint position sense. And then balance problems I look for by evaluating walking in a straight line. I want to talk about symptom management in neuropathy. This is important. Bracing, such as ankle foot orthotics, help prevent the foot from catching, and that can prevent falls. Gait stabilization via physical therapy, and then also by gait aids, such as canes or walking sticks or walkers, are important. Medication for nerve pain is commonly used because that pain can really interfere with what somebody wants to get done. The GABAoids, gabapentin, pregabalin, are very commonly used. They're well tolerated for the most part. At higher doses, you may see some sedation. The medications are safe. They've been used for many years. Serotonin and norepinephrine reuptake inhibitors, or SNRIs, venlafaxine and duloxetine, you may have heard of these. These can help reduce pain. Their side effects can involve mood changes, energy changes, sexual dysfunction. And I will mention tricyclic antidepressants. They've been used for many, many years and can be effective, but really have to be cautious because of potential effects on the heart and can worsen or cause orthostatic hypotension. And if we're talking about treatment of carpal tunnel using wrist splints that are firm across the wrist, or undergoing surgery to release the carpal tunnel is effective. And I want to mention a little bit about the autonomic symptoms because they can significantly impair a person's ability to function. And I mentioned orthostatic hypotension. Treatment for that is thigh-high compression stockings combined with an abdominal binder, increasing fluid and salt intake. Of course, this has to be balanced with any cardiac disease. There are medications if those initial approaches are ineffective. Midodrine, fludrocortisone, both of those have a risk of increasing your blood pressure when you lie down. And then some other agents that have been used more recently, pyridostigmine or droxidopa, may be helpful for those symptoms of lightheadedness when you stand. Speaking to gastrointestinal side effects, fiber to increase the bulk of the stool, or loperamide that can reduce bowel motility. There are agents that are used to increase the transit across the stomach as well, such as Reglan and domperidone. Treatments that directly impact the organization of the fibrils themselves involve membrane stabilizers, tafamidis and diflunisal. You've heard about these from Dr. Cheng. They prevent that dissociation of that tetramer to the monomer, which is where we get into trouble, where there's protein misfolding and ultimately amyloid fibril formation. And then there are gene silencing agents, inotersen and patisiran, I will be talking about, and those substantially reduce the amount of the TTR protein levels by degrading the TTR mRNA. That's the messenger RNA that's telling us what proteins to form. So first, the membrane stabilizer diflunisal, which is an anti-inflammatory. This is an agent that binds at the tetrameric TTR, stabilizing that TTR so that you don't have that dissociation into the monomers and ultimately fibril formation. Looking at a 2-year placebo-controlled study of 130 subjects, the progression of neuropathy was significantly less. This was measured on the neuropathy impairment score, and also quality of life scores showed a decrease in worsening, so decrease in the progression of the disease. Neurological stability was seen at 2 years in 27% of the patients that were treated, compared to 9% of those in the placebo arm. Side effects include kidney dysfunction, decrease in platelets, and then NSAIDs have gastrointestinal side effects. And so the use of these agents, this agent is limited in anybody with potentially heart or kidney dysfunction. The other membrane stabilizer I'm going to talk about, tafamidis, will stabilize the TTR tetramers also by inhibiting dissociation into those monomers. A study of 120 patients with the most common Val30 MET mutation did not meet primary endpoints. This was quality of life and prevention of progression of the neuropathy in the legs. There was an open label study subsequently looking at 1 year and even up to 5.5 years that did show reduced neurological deterioration. So patients did not get worse as quickly. And there was delayed worsening, and this was seen in early onset disease. A retrospective survival analysis suggested, and to qualify, retrospective means somebody looks back at the information instead of has an active plan with a placebo control moving forward to see the impacts. but that suggested that there was a 91% reduced risk of death in patients treated with tafamidis in this very large cohort, but it was retrospective. So mixed outcomes in patients with later stage disease in any of the mutations, and then limited impact on polyneuropathy did not lead this drug to be accepted by the FDA for use in the United States for neuropathy. Moving on to the transthyretin gene silencers, inotersen is an antisense oligonucleotide. It binds to the messenger RNA that's going to produce that protein, and it prevents that translation. It's a weekly subcutaneous, so under the skin injection. And this study that looked at 172 people, in addition to a 2-year open label study following that, showed that there was benefit in slowing, in some cases actually improving the neuropathy score by this neuropathy impairment scale. And then also improvement in quality of life based on the Norfolk assessment. There were, however, safety concerns with drop in platelets called thrombocytopenia, and then also kidney dysfunction. And this requires frequent blood monitoring to make sure that those effects are not seen. Patisiran is another transthyretin gene silencer. It is a small interfering RNA. It targets a sequence, again, of that messenger RNA in forming TTR. It inhibits the synthesis in the liver. The infusion is intravenously, and that has to be done every 3 weeks. This was shown to slow, stop, or improve the measure of neuropathy, that NIS score, in 225 patients over 18 months. And the disease stabilization was seen in an open label extension up to 29 months. Also, preserved walking speed and weight as measured by body mass index were seen. Side effects include peripheral edema or swelling, infections, upper respiratory infections, and then infusion reactions may be seen as well. I want to mention liver transplant. Historically, this was a standard of care, as the liver is the main producer of amyloid. And early liver transplant in the common mutation Val30 MET carriers showed better rates of survival at 10 years. But different variants have better survival rates with this transplant, while others did not. And limitations are availability of organs, high cost, and then lifelong immune suppression required with this. We are currently enrolling for a multi-center trial of the TTR transform, which is an antisense oligonucleotide with less risk of, or no risk of, the thrombocytopenia and glomerulonephritis. And it will be interesting to see what the outcome is with that. That is not a placebo-controlled trial. The control wing is the inotersen, which is already approved. So in summary, nerves are commonly involved in the TTR amyloidosis. There are many treatments options. Some are supportive care, but there now are available treatments that actually act on altering the outcome in the neuropathy. And this is not, I'm not going to say unheard of, but this is very unusual in neuropathies in general. We often have very limited strategies on how to help stop the neuropathy from progressing. And then there are lots of different management pieces that are important. And I will end there. Thank you so much for your attention.
Thank you so much, Dr. Distad. That was really helpful. And we do have quite a few questions, which we're going to save to the end because we're running out of time. And I want to make sure we get all our questions in at the end. So make sure all of our doctors hang around. Otherwise, you're in deep, you know what. Okay, Dr. Masri, take it away.
All right, fantastic. That was great, Dr. Distad. If Dr. Libby is with us, then we can move and discuss MGUS, light chain amyloidosis, and what all of this means. Why is it written in my chart? Dr. Libby is an associate professor of medicine. He is an oncologist at the University of Washington.
All right, thank you. I'm glad to be on board here and always thrilled to be part of these talks because it's so important and these are such incredible diseases. I am the co-director for our multidisciplinary amyloid clinic at the University of Washington along with Richard Cheng. And what I'm going to talk about very briefly right now is why do people who end up having ATTR type amyloidosis need to get all these tests to look for light chain amyloidosis? So I just want to touch on that subject briefly. Why do you have to see a hematologist oncologist often? Okay, so let's see here. Okay, first I want to start with just some basic facts that are the background to my talk. Number one is that there is an entity called monoclonal gammopathy of undetermined significance, or MGUS. And MGUS means that there's an abnormal protein that's been detected in your blood. An abnormal protein, generally it's found in your bloodstream. It's quite common, and it's particularly common in the elderly. Once you get to be over 50, more than 3% of patients have it. So I have a chance. I'm over 50, but I'm less than 70. I have a 1 in 30 chance of having MGUS. I've never been checked. If you're over 70, then you have a 1 in 20 chance of having MGUS. And if you're 85 or older, it's almost 1 in 10 people have MGUS. It's a very common condition. And so the fact that you have an abnormal protein in your bloodstream can mean something bad, like you have multiple myeloma, which is a cancer that requires chemo, or light chain amyloid, which is not a cancer, but it requires chemo. But most of the time, having an abnormal protein in your blood is completely asymptomatic and nothing needs to be done. All we need to do is follow it once a year to make sure that it doesn't turn into something bad. So this is very common, and generally it's not a problem, but sometimes it is. Fact number two is that amyloid is a descriptive term. In many ways, it primarily gives us a description of what we're seeing. So it tells, when you see amyloid in the body, you're saying, I saw some gunk or some junk in the body that's stained with that when I put a particular ink on it called Congo red, the ink stuck to the stuff that we saw in the body. So if you've had a biopsy that demonstrated amyloid, we still don't really know your final diagnosis. There's still more work to be done. We're really, in many ways, only halfway to a final diagnosis if a biopsy stains positive for amyloid with Congo red dye. We still need to know, okay, it's amyloid, but what kind of amyloid? There's several different, fact number three in our background is there are several different types of amyloid. Light chain amyloid is the most common form of amyloid. It's caused by abnormal cells in the bone marrow, and you have to get chemotherapy for it. Wild type amyloidosis is more and more frequently diagnosed. It's becoming less and less rare, but it's caused by the TTR protein produced by the liver. And finally, mutated TTR amyloid or inherited amyloid is truly rare. It's also caused by an abnormal TTR protein, but it's a mutant TTR protein produced by the liver. So there are several different types of amyloid, and it's critical for your doctor who's treating you to know which kind it is. So here's just a picture of a kidney where someone put a needle in a kidney and got some pieces of the kidney, and then they said, well, is there amyloid? They saw some gunk. If you see here, some gunk in the kidney, and they said, what is that gunk? What is that? Maybe it's amyloid. Let's put some special dye on it, which we call Congo red dye. And if that dye sticks to the gunk, it's amyloid. And that's what happened in this kidney. So this kidney, the Congo red dye stuck to the gunk or the junk, and now we know it's amyloid, but we don't know what type it is. So, and that's critical because depending on which type, it's treated differently. So light chain amyloid is caused by plasma cells some sick plasma cells in your bone marrow. This would be your leg bone here. Normally, we all have plasma cells in our body, all of us, and what they do all day long is make antibodies to fight infections. That's the normal situation. These little pitchforks are antibodies that normal plasma cells make to fight infections. But in the abnormal situation, these plasma cells become sick. You can see that the artist has made them look abnormal. There are more of them present in the marrow, and they produce a whole bunch of these antibody pitchfork things. And the last little trick to this in amyloid is these proteins are screwed up. These antibodies that are now being produced by these abnormal cells, the antibodies themselves are abnormal, and they collect, deposit, and destroy various organs in the body. That's the light chain amyloid situation. In mutant amyloidosis, I like this slide. I found it this morning, so I'm not here to represent on Patro, but as is said several times, the abnormal protein is TTR, transthyretin. That's produced in the liver. Everybody has transthyretin, but it's mutated in the inherited form, and it folds abnormally and deposits in the body. Again, we need to know which type of amyloid it is, and just finding junk in the body that stains with Congo red, we still don't know what type it is. So your doctor is thinking this as they're trying to figure out, gosh, does my patient have amyloid, and how do I figure out if they do and what type of amyloid they have? So this is really the situation. The dilemma for your doc is, well, my patient may have amyloid, but what type? There are many different types of amyloid. This is not the full list, but there's light chain amyloid, there's hereditary amyloid, there's reactive amyloid from chronic infections or inflammation, and then there's this old-fashioned name senile or wild-type amyloid. Well, a big problem, there's several types of amyloid, and these little pluses tell us if this is seen in the patient. Well, in AL amyloidosis, the heart is often affected. Well, in hereditary amyloidosis, the heart can be affected. In senile amyloidosis, the heart is affected. So clinically, when your doctor is saying, well, what are you feeling? What's bothering you? These diseases are all very similar. The same thing, these diseases can also affect the kidney. They can also affect the nervous system. So it's not easy just talking to the patient and examining them. You may be pretty convinced they have amyloid, but you really don't know which type it is. The clinical exam doesn't necessarily give you the answer. So we have to do more specific tests. The most common type of amyloid is by far light chain amyloid, the type I first spoke about. This problem is diagnosed and managed by hematologists and oncologists. So that's why you end up in a cancer center. So my amyloid patients have to come to the 8-story tall Seattle Cancer Care Alliance, and they're terrified because they see the big word cancer on the building. But amyloid is not cancer. It can be just as bad, but it's not a cancer. But the doctors who take care of AL amyloidosis or light chain are hematologists, oncologists. At a minimum, to rule in or to rule out light chain amyloid, and this needs to be done for every patient that you suspect amyloid in, you need to do blood and urine testing to check to see if they have amyloid, if they have those abnormal proteins in the blood or the urine that I showed you earlier. And often, we have to also do a bone marrow biopsy. Now, light chain amyloid is treated with chemotherapy. TTR, or wild-type amyloidosis, is treated with a pill called tafamidis. The mutant TTR is treated with an injection called patisiran or Tegsedi, or Onpattro or Tegsedi. So there are also some other types of amyloid that have other treatments. So it's critical that we know which type it is, and we have to do this testing. So the first thing that has to be done when your doctor is suspicious, whether it's your cardiologist or it's your gastroenterologist, they found amyloid in your intestines, or it's your primary care doctor or your hematologist oncologist, is one of the first things that have to be done is blood and urine tests to look for those abnormal proteins. Any doctor can order them, but usually a hematologist oncologist orders and interprets them. More and more, the cardiologist is doing this for us. So they're making our work much easier because they're doing a lot of this work in advance. But often none of this is done, and somebody has amyloid and they just show up in your clinic, and the hemo doc has to figure out what's going on. If there are no light chains in the blood or urine, then light chain amyloidosis is ruled out. If you don't find those light chains in the blood or urine, we're done. It's not light chain amyloid. It may be some other type, but it's not. But it's not light chain. And you would determine the other types by taking the biopsy and studying it, which has already been described. The basic part is, how do we rule out one of the most common forms of amyloid? And when we're worried about amyloid, we need to make sure that it's not light chain, is to get blood and urine tests. And often your friendly hematologist, oncologist will become involved, but they may quickly say, you don't need to see me. I'm going to send you to Dr. Cheng or Dr. Masri, and they're going to manage this problem. Thank you very much for listening.
Thank you, Dr. Libby. I like your little scruffy beard that you've got there going. Thank you.
Scruffy?
Oh, I have to study my adjectives and my synonyms. I'm not very good at that. Okay, again, we're going to hold off the questions till the end. So Dr. Masri, take it away.
Okay, I guess just for the sake of time, we can move forward and have Dr. Hongya Chen talk to us about medications, cost, and insurance. I have the pleasure of working with Dr. Chen, and I looked at the participants. Many of you know him, and know that he's actually the one behind, the success that we've been having with all the medications and therapies we prescribe for you. So I thought it would be great to hear from him and his perspective on how things work out in the insurance space. So I turn it over to Dr. Chen.
Hi, everyone. As Dr. Masri said, my name is Hongya Chen. I'm the clinical pharmacist at OHSU, Cardiac Amyloidosis Center. Today, I'll just kind of go through about the behind the scene about these medications when they're prescribed and how we navigate through this complexity of our healthcare system. So this slide kind of tells us about what happens from diagnosis to treatment. As all the excellent doctors have talked about how they diagnose amyloidosis for ATTR type. So we have 3 medications here that are very expensive, and that are the 3 that we often deal with after the diagnosis is made. Tafamidis capsules is the oral option that we most commonly use. This medication has to be dispensed at specialty pharmacy due to its high cost. Specialty medications are defined as either high cost or they have some high risk that requires monitoring, or any biologicals. Tafamidis is a category because of its high cost. PA is usually required. PA is prior authorization. So all these medications, because of its high cost or high risk, it requires a prior authorization that's completed by the provider. I usually help with this. That way we can do it quickly, and then we can find out the copay afterwards. As far as inotersen, sub-Q injection or patisiran infusion, these 2 are a little bit different. Now the manufacturer require you to enroll with them so that they can have a nurse coordinator that can help out with this, with the care. So inotersen injection, when you first prescribe, it needs to be enrolled, usually online, but there's also paperwork form that needs to be completed. This is also dispensed in a specialty pharmacy. Besides its high cost, it also has a risk for different rare side effects that needs to be monitored. So it's categorized also as a specialty drug. PA is also required, and then we'll find out copay after the PA is approved. Patisiran infusion is different from inotersen sub-Q injection in that it's used in the infusion clinic. So this it's not to be used at home unless there's an infusion nurse that comes to your home to do it. So this is usually taken care of by an infusion pharmacy to coordinate. This is a slide about medication costs in general. If you look at tafamidis, The average wholesaler price for the year is $270,000. And Tersen is about $370,000. Patisiran, just the drug itself, costs over $500,000 a year. That's not including the infusion-related cost at the infusion center or the nursing infusion cost. The copays will always depend on the insurance. If you have a commercial insurance, like a non-Medicare insurance, or if you have Medicare insurance, the copay can vary. But all of these medications are at the highest tier because of its cost or the specialty category. I want to highlight a little bit on the Medicare side because the majority of our patients have Medicare insurance. Tafamidis and Tersen will use your Part D benefit as in your prescription benefit. Patisiran, on the other hand, will be covered under your medical, usually Part B plan. So now we know the copay, what happens afterwards. So as all of us are aware, this high cost, even copay, will need some assistance. So our pathway, our OHSU, kind of the way I work with our medication assistance team is as follows. So when you have someone's copay, then we ask the patient, is this something that's not affordable? And usually the answer is yes. So then we go down the pathway of, is this a Medicare insurance or a commercial insurance? A lot of the Medicare side, it will depend on the income, unfortunately. So there is the calculator that all the charity organization or manufacturer use, FPL, which is federal poverty level. Depending on that, then we can see which program that you might qualify. On the commercial side, it's actually a lot easier because there is no federal anti-kickback law that's preventing this patient using their copay card, which all the manufacturers offer to reduce copay. So it's much easier on the commercial side. Some of the foundation grants that's available right now, especially for Medicare patients, are these three: Penn Foundation, Healthwell Foundation, and the Assistance Fund. As you can see, the criteria, they are usually about the same, except the income level is a little bit higher, meaning you can make more money and still qualify in the Assistance Fund. On the bottom part of the slide, you can see about, what does the income look like. So if you have a family of one, 400 or 500% will be about 50 to 65,000 for the year as your household income. And for Penn Foundation, Healthwell Foundation, you get a one-time grant that can use towards your copay. And we find this is helpful, but it will not cover for the whole year, especially for tafamidis, because the copay is significant. The assistance, on the other hand, is much better in that there's no cap for the year. Once you're qualified, they reduce your copay for the whole year. We did publish this paper last year, me and Dr. Masri and some of our staff, about our early tafamidis experience at OHSU. As you can see, we were successfully getting patient qualified with tafamidis up to 86%. On the left side here, you can see the graph. Once you receive assistance, you pay almost about zero copay for majority of them. The people who do pay with some assistance, they also lower their cost. So the financial assistance component is very important for this patient to get their medications. So I think 2020 and 2021, the coverage and assistance are better in that there seems to be a little bit more funding in these foundational grants. We work closely to the manufacturer assistance programs to get patient enrolled and assess their financial status and get anything we can do to help these patients to get the medication they need. So in summary, these ATTR treatments are some of the most expensive treatments in cardiac history. And that is because the category of their specialty tier, that's copays are largely unaffordable. The access to assistance programs are very important, but they are primarily depending on the type of insurance and household income. And I think a model with a clinical pharmacist and a really good medication assistance program at a hospital is very important to secure patients' access to these medications. And that's all I have for today. We'll answer some more questions later on if you guys have any. So thank you for your time.
Thank you so much, Dr. Chen. It's something that everyone always is interested in and has questions in. And Paula put in the chat some links to the organizations that you listed in your presentation. So that should be helpful for people as well. And we'll be, right now, I think we're going to be going to Dr. Moshe-Lilie. Dr. Masri, what do you think?
Yes, looks like it's working now. So as I said, Dr. Moshe-Lilie is a neurologist at OHSU. She's actually moving next year to, or next academic year to Boston. So most of the attendees here are from the Pacific Northwest, but since this is recorded, some of you might see her in the future on the East Coast. So I'll turn it over to you, Orly.
Thank you so much, Dr. Masri, and my apologies for the bumpy start. I would like to thank Dr. Libby and Chen for jumping ahead. Thank you. It is my privilege to join you this morning to kind of go over some of the basic studies that we often order. I'm sure most of the patients here today have either undergone most of them, if not all of them, with maybe perhaps a limited discussion by their provider about the utility of ordering these to, you know, in arriving to the next diagnosis, or the right diagnosis. So I'll get started with a nerve conduction study. This is one of the studies that are most often ordered by the neurologist or cardiologist. What we do with nerve conduction study is that we do put electrical stickers on a muscle that is innervated either by a motor nerve, or we do studies in sensory nerves, and we provide very small, safe electrical pulses. Even though they're very small and safe, they can be uncomfortable. However, there's no long-term effects in this study. And what we measure is really the fastest conducting nerves. So about 20% of those axons firing in those nerves are being tested in this study, not the small unmyelinated or limited myelinated nerves that I'll talk about later. What we get from this study is either assessing the integrity of the myelin, which is the kind of the yellow coating in this image that coats and protect the axon and allow to transmit the information rather rapidly. And so we measure velocities, which tells us if the conduction is slow or too fast, and we measure latency, whether the information transmitted in the nerve is timely versus delayed. And we can also gather information about the integrity of the axon fiber itself, whether there is disruption, conduction block, or injury to that nerve. And often the amplitude of the waveform tells us information about the quantity of those axons participating in the captured information. We can also do an EMG, which basically is when we poke the patient in various muscles. We use a very thin needle, and it's often can be a little bit uncomfortable, especially when we ask the patient to activate. The muscle can get squeezed a little bit around the muscle and can cause some discomfort, but it should be tolerable. And then we measure the electrical activity in the muscle. So here you can see in A, there is a very normal waveform for a motor unit action potential. It's called a triphasic form. It goes down and then up and then down again. However, if there is ongoing injury, you can see that instead of one, those 20% fibers, instead of firing very uniformly, you get multiple nerves trying to innervate that area of injury. And so you have multiple smaller units joining together to what we call a polyphasic unit potential. The information that we get from an EMG can be useful because it can tell us, is there a nerve or muscle damage that has occurred in the past? Is there an ongoing damage? So whether there's an active irritability that we often see with amyloid, whether there's evidence of recovery. So when we do see reintervention in polyphasic units, it does tell us that there is some recovery going on, which is important when we discuss prognosis with patients. And then whether there's a target of muscle to biopsy. We don't want to biopsy a muscle that appears to have healthy units, because then we might miss out amyloidosis if the disease is patchy and that specific muscle that was biopsied was the wrong one. So one of the utilities of nerve conduction study is for carpal tunnel, as Dr. Mooney and Distad mentioned. It's very common and often very severe, and then involves both hands. Unfortunately, it's not specific for TTR amyloidosis, but it can help you depending on the clinical state. What we look for in the median nerve or carpal tunnel is when you have amyloid deposits within the nerve sheath that causes it to swell or to enlarge, and that median nerve is captured below that transverse carpal ligament, which is already a tight space. And when that occurs, that swelling causes irritation to the myelin coating. And so you can see here in the picture below, you can see that the worse the diagnosis or the worse the carpal tunnel, the more delayed response gets. And then the more coating is disrupted, the axon itself can then be injured. We call it a secondary axonal loss, leading to loss of fibers. And then the most, as the disease progresses and as the median neuropathy gets severe, the amplitude even decreases. So it can give us a diagnosis of carpal tunnel and severity pretty early on, and especially it's important if we're suspecting amyloidosis. The other utility of nerve conduction studies, as Dr. Distad mentioned, patients will come to her with symptoms of kind of like a saw glove distribution, telling them they have numbness, tingling, etc. And so if we do a study and we arrive to a specific pattern of a saw glove distribution, meaning the distal most leg or feet are affected, as the disease progresses to involve the shins or the knees, it should also be expected to involve the hands and maybe the forearm. And it's usually very symmetric and on both sides. And when we see this pattern on nerve conduction study, we arrive with the diagnosis of a large fiber peripheral axonal neuropathy, which often what we see with amyloidosis. Again, this is not a test for small fiber neuropathy. Often the symptoms will start with small fiber neuropathy. However, the role here is to evaluate whether there is large fiber involvement, which can put the patient, possibly being amenable to medication if they do have neuropathy. Small fiber neuropathy is really what brings the patients to see the neurologist early on, because it really can disrupt the quality of life. They have usually involvement of those really tiny, thinly myelinated or unmyelinated sensory fibers that lead to impaired thermal and pain threshold. And so the patient will feel that their feet are either very cold or they're very burning and painful, or they can also have allodynia, which means that even the simplest thing can cause them discomfort, such as putting the bed sheet over their toes, cause them great discomfort. Sometimes they'll even use things, things like, I feel like I have a wrinkle in my sock, or I have sand in my shoe or a pebble, and this really should suggest to the neurologist to go ahead and look for small fiber neuropathy. Really, the gold standard for small fiber neuropathy is a skin biopsy. What we do is we take a very small part. It's a punch biopsy, about a 2 to 3 millimeter. We usually do that at least in 2 spots. One is in the thigh and one is in the distal leg close to the ankle. There's no stitches needed. It's very straightforward. And what I like about this procedure is that it's the most least invasive procedure or biopsy that a patient can have, meaning to reach to a pathology or a tissue biopsy that will provide you with results. What we look for is to quantify the number of small fibers that we have in our epidermis. So if you can see here in that purple picture, in the top where you have that arrowhead, you can see this small fiber going up to the within the epidermis layer, going into our allowing appropriate sensation of the skin. Whereas in the bottom picture with all those areas, you can see there's almost no nerve fibers there in the epidermis. And so reduced density of those nerve fibers or complete loss of those fibers is highly suggestive of small fiber neuropathy. What I like about the skin biopsy test is that it's very common and very easy to do. And what we can do is to utilize it specifically for diagnosis of amyloidosis. As Dr. Mooney and Distad mentioned before, you can use a Congo red dye to stain those amyloid plaques. As you can see in the top picture, all those insoluble particles that are stained in kind of peach color can tell us whether there is amyloid, in the skin, and which can really point us early on to the diagnosis of amyloidosis without having to do more invasive procedures. It does have a really high yield. If we haven't seen anything in the skin, what the neurologist will do if they see evidence of peripheral neuropathy or nerve conduction study will be to proceed with a nerve biopsy. We often do choose the serial nerve because there's a least amount of damage that we can do. And often it's just a small area in the distal leg or lateral leg that can just have numbness post-procedure. And often patients already have numbness because they have neuropathy. And so this is not as significant for them to have a small part of that serial nerve taken. And then what we do again is we stain it for Congo red dye. And you can see here within the surrounding the nerve sheet, you can see amyloid plaques here. And then again, if we use a polarized light, you can see the birefringence of those amyloid plaques within the nerve fiber. And the yield is very high, it's about up to 87%. However, I would like to emphasize with serial nerve biopsies is that amyloidosis can be patchy. And so if the neurologist's concern is pretty high, a negative serial nerve biopsy should not deter for proceeding with additional investigative studies. The next thing that we can do, especially if the patient discloses proximal muscle weakness, is to proceed with a muscle biopsy. So if we've done the EMG and we found a muscle that has abnormalities in their motor unit action potential, we can then refer them for a muscle biopsy. Usually myopathy will follow neuropathy after months, if not years, and it often follows heart complications. So usually you would see the neurologist or the cardiac doctor prior to seeing or prior to have weakness and to proceed with a muscle biopsy. We can either biopsy a skeletal muscle, such as the thighs, or we can do a cardiac muscle tissue as discussed before. And again, we use the same dyes as we mentioned here. So here in the middle where you see the pink picture and the small arrowhead, this is basically a muscle fiber that has degenerated and atrophied. So you can see a difference in color. It looks more bluish. And then on the side here on the bottom left, you can see in red those amyloid deposits in those areas of the connective tissue and the surrounding blood vessels within the muscle. And then in the top, you can see the birefringence, and easily you can see how amyloid gets deposited around the nerve, around the muscle fibers in this biopsy. I'll transition to autonomic nervous testing, and I'll say that, you probably all had some variety of autonomic testing. Each institution kind of picks their own. I sampled the ones that are done most often, just to, to give you the best information about what you probably will undergo. The first thing is what we call the QSART. It's the quantitative pseudomotor axon reflex, testing the ability for the nerve to produce or secrete acetylcholine and to cause a sweat response. When you look on the left side, you see the postganglionic fibers. And what we don't do is we don't care about, when we give patients capsules with acetylcholine, we don't care about the immediate response, whether the nerves can detect that acetylcholine. What we would like to measure is that indirect response where you'll have this antidromic response going to a nearby fiber and checking whether that fiber can secrete its own intrinsic acetylcholine, leading to a sweat response. And often it can tell us how well those nerves and those sweat glands are functioning. And it has a very high sensitivity of about 75 to even up to 90%, meaning that if this test is positive, it can really accurately and in a correctly manner tell us whether you have dysfunction or not, leading to a diagnosis of dysautonomia. And you can see in the picture on the right, the green arrow, the first green arrow shows you when acetylcholine was provided in the capsule over either the distal leg, the ankle, or the proximal leg, or over the hand. And usually a normal response is after the acetylcholine has been secreted, it takes about 1 to 2 minutes for the indirect response to occur. And then over 5 minutes, you have increased sweat production, and then it kind of dissipates. This picture shows you an abnormal response. So in the bottom is the feet, and you can see that after more than 1 to 2 minutes, even after 5 minutes, you don't have a rise in a sweat response. It's almost, minimal to absent. And then as the patient was tested in their distal leg, farther away from the foot, there was some response. And as you go up to proximal thigh, you see some, greater response, and up top in the red is the forearm. And you can see the forearm is the least or minimally affected. And so it has almost a very normal sweat response. This would fit a length-dependent distribution that I mentioned before, where usually the feet are most affected, and then the distal leg, thigh, and the forearm. This is another test called the thermoregulatory test. I know they do it in Mayo, but it's often very tedious, messy, and time-consuming. The patient is being told to enter into a chamber that is designed like a sauna to create high humidity conditions that are very uncomfortable. They ask the patient to lie on a bed, and then they powder the patient with a yellow substance that basically turns to purple once the patient starts sweating in this very closed sauna. What it does help, though, is to detect dysfunction in patients who don't have the usual pattern of length-dependent neuropathies. It can help when the pattern of dysfunction is actually variable, multifocal, patchy, as you can see here in the pictures. You have that picture where it says global. You see the entire patient is yellow, other than their left foot is purple. So they're really just sweating in one foot. Whereas you can see a multifocal patchiness where some parts turned purple and some parts remain yellow, and those are the parts that the patient is not sweating. So it can help in those messy situations. The next thing that I'll present is the heart rate response to deep breathing. This is a really high yield test. It's very easy, less invasive, and really helps distinguishing whether there is a disruption in the parasympathetic response. Again, that will help us diagnose dysautonomia with patients with amyloid. And it's 80% specific, meaning if the test is negative, it's pretty much correctly telling us that the patient does not have the problem. So in the bottom part, we can see a normal magnitude of heart rate variability. We ask patients to take deep breaths, often only 6 per minute. And we see a high variability where when you're inspiring, your heart rate should increase, and when you're expiring, the heart rate should decrease, and so on. And in the top part, you can see a patient who has a very limited variability in the heart rate response, showing dysfunction in their parasympathetic response. Of course, the results can vary by age, by patient's posture, and what medication they're on. So the provider should always review medication lists with the patients before ordering this autonomic testing and guide them whether they should hold some of the medications day of the procedure or the day prior to the procedure. This test is called the Valsalva maneuver. It's very common. It's assessing the vagal or cranial nerve 10 function, where we ask the patient to take a really deep breath, and then we have them blow out into a plastic bugle against some sort of a resistance. And then we measure their expiratory pressure. So normally when we ask someone to expire really forcefully, we'll see some elevation in the heart rate, which you'll see in the top, causing tachycardia. And the blood pressure should cause some changes, whether up or down, because when you're blowing out, you're causing more pressure in your thoracic area, causing pressure on your heart and your vessels. And when you release, or when we ask you to stop or relaxing, then the thorax expands, and then your heart fills and your blood pressure is supposed to drop. And what we test here is whether the patient has inability to tighten their vessels. So in a normal response, we'll see an elevation in phase 1, a slight drop in phase 2, and then we should see an elevation when the patient expires through resistance, and then we should see a drop when they're relaxing. This is in our normal response, where we see a patient, once they start blowing, the blood pressure continues to drop, and it kind of tanks really down until phase 3. And even the recovery here is abnormal. Instead of a fast recovery, it takes these specific patients multiple minutes until they recover to their prior blood pressure prior to testing. So that significant drop in blood pressure with a very delayed and slowed recovery is really significant for a dysautonomia of the cranial nerve 10 and would suggest a diagnosis as well. It can vary with age, gender, and medication. And again, we always have to be cautious when we interpret these results, and we do those against the normal for gender and age. And then lastly, I will talk about the TIL test that not all facilities do. I know that definitely we do them in OHSU and in Mayo Clinic. And what we do here is we try to see whether the patient has an ability, a cardiovascular ability, to accommodate when they basically move or transition from a laying position to a seated position and then to a standing position. It's very helpful to diagnose orthostatic hypotension and vasovagal syncope, as Dr. Distad and Mooney mentioned, especially when there's heart issues and people complain of syncope. This is an important test to order. And so what we do is we basically lay the patient on a bed, and we tilt the patient up to 70 or 75 degrees just to kind of get the heart going and get more anti-gravity without using a full stance. In a normal response, your heart rate should rise just a little bit by about 10 beats per minute, but not more. And there shouldn't really be any changes in the blood pressure. So you can see here in the first picture to the right from the tilt, you see in black that the systolic blood pressure and diastolic blood pressure are really remain the same. When someone has orthostatic hypotension or some sort of adrenergic failure, you can see here that as soon as we tilted them, their blood pressure, systolic blood pressure and diastolic blood pressure significantly drop. And if the drop in systolic pressure is more than 20 beats per minute, and if the diastolic blood pressure drops again by more than 10, and if the heart rate rises too much as well, that's signify orthostatic hypertension or adrenergic failure. Now, in a patient who has a vasovagal syncope or disruption or dysautonomia, if you leave them tilted for too high, the tech can start seeing a drop in blood pressure. And if you don't tilt them back to a laying position, this drop will just precipitously continue until they pass out. This is an exaggerated example. Often the techs will not let it happen. So once they see a huge drop in blood pressure or heart rate, they will immediately tilt the patient back to prevent from syncope from occurring. Patients can feel lightheaded or faint, and that's usually normal if they do have dysfunction. However, we do want to avoid from them actually passing out during the procedure. I think this is where most of our testing concludes. I think the big picture is to make sure that we do not one, but multitude of testing to kind of reach a unified diagnosis. So if someone does have neuropathy and does have cardiac symptoms or symptoms of autonomic dysfunction, it's important to order all these tests to arrive to a most accurate and early diagnosis to kind of lead to medication early on to prevent need of heart transplant. Thank you all again.
Thank you so much, Dr. Moshe-Lilie. That was the first time I ever heard about the sauna, so that's very interesting. Where in Boston will you be going? Which one of the 3 centers?
The Boston VA and BU.
Oh, okay, great. We look forward to meeting with you there when we have our Boston meetings.
Thanks.
Dr. Masri?
All right, great. Well, thank you all. I know it's we're coming up to 2 hours there, so I'll try to be as brief as possible. I'll be talking about some of the advances and new therapies in transthyretin amyloidosis. These are my disclosures, and I want to just highlight some because I'll be talking about clinical trials. And so I have some grants from some of the manufacturer of some of these medications. OHSU receives fees for clinical trial activities. The most pertinent ones are Pfizer, Ionis, Axia, Eidos, Prothena, and Alanylam. And then I'll be discussing a lot of medications that are not FDA approved. And so when I think about the future of amyloidosis, there are a lot of angles there, but the main 4 quadrants that I think about are pathobiology, imaging and biomarkers, newer therapies, silencer stabilizers, and gene editing, as well as the fibril depleter remover. And I put this separate because it's an exciting area. It's a bit different. All of these are targeting the same problem, which is either stabilizing or removing the protein, while the fibril depleter are going to the tissue and trying to extract or deplete or remove what's already been deposited there. And so this talk will focus on these 2 areas here. And so some basic concepts, and sometimes, especially with the first one, we typically tell our patients that placebo-only arm should no longer be acceptable in 2021. There are some certain scenarios where we cannot get the medication to patients because of financial reasons, but those are becoming very, very uncommon. And so, as you heard from Dr. Chen and others, coverage is becoming better. There are a lot of routes also to get some assistance. So for us, there are placebo-controlled trials still ongoing, but there are, you need to be mindful that standard of care therapy should still be allowed when possible. ATTR trials for hereditary TTR will always be different from wild type. So you cannot really compare them in a way. They all are designed differently. And thanks to tafamidis, a track trial, they've designed it in a way that set a precedent for any regulatory trial. So anytime now there's going to be a wild type TTR trial, it's going to copy from the ATTRACT trial design. Silencers versus stabilizers, there's a lot to learn there. We'll know more in about 3 to 4 years timeline, not head to head, but something close to that. There is a large unmet need for fiber removal. And then we really need a revolution of how we think about TTR amyloidosis. Dr. Libby mentioned that amyloidosis is not a cancer, and truly it's not a cancer, but we also should borrow from oncology how we think about this. It's a progressive disease. It continues to progress over time. It infiltrates tissues. Cardiologists are really not used to diseases like that. And so the way I think about amyloidosis is that we really have to jump on this and think about always clinical trials on top of the standard of care therapies, because the more we learn, the more we know and advance the disease, and hopefully it becomes a curable disease. And so starting with the new stabilizers, many of you have heard about AG10. What it does is it's similar to tafamidis, but different mechanism of action. It binds to the transthyretin. So imagine this is your tetramer for the transthyretin. It utilizes a naturally occurring mutation called T119, stabilizes the compound, the TTR, preventing it from going to the heart again. The trial was completed in 2020, completed enrollment, 632 participants. We should be hearing about the first assessment by maybe end of 2021. And the trial design will help us also understand a little bit how tafamidis compares to AG10, because after 1 year of randomization, they allowed tafamidis, and so we will have some data there. There is another study called Attribute Peripheral Neuropathy trial, which is AG10 versus placebo. It has started, I think, in Europe already. Next, we will be talking about silencers. And many of the physicians already have covered the ones we already commercially have, so I'm not going to repeat that. But those are the next generation. You have one, it doesn't have really a catchy name yet. We call it the LICA molecule, which is essentially a second generation of inotorsin. It prevents the translation or the production of transthyretin to the blood from the liver. Vutrisiran is also a subcutaneous medication from the same company that produces patisiran, Alanylam. And this is a complex mechanism, but the bottom line is the same. You want to stop that production of transthyretin as much as you can. And these are the phase 1 clinical data showing that when you give the medication different doses, you essentially make the TTR not produced by 94%, 86, depending on the dose you're talking about, similarly with different doses of vutrisiran. And we'll talk a little bit more about that. So the first trial in cardiomyopathy with a silencer is CardioTransform. This is a trial where patients will be taken, even if they are on tafamidis. There are no restrictions there. You can start tafamidis at any point in time, and then they would be randomized 1-to-1. I think this would be the largest amyloid trial to date, and even considering the ones which are in design right now, you will be randomized to that LICA molecule versus placebo. 120 weeks. Consider site visits about once on average every 3 months, and then you will have a weekly visit from a nurse with blood monitoring. This might change with time, we don't know yet. And then we're measuring really hard endpoints, cardiovascular death, frequency of clinical events, and whatnot. The second one is NeuroTransform. It's the same exact concept, but there is a catch here, is that it's open label, so everyone gets treated. The one downside is that tafamidis is not allowed, and so you cannot be getting the therapy and tafamidis at the same time. Only a small group of patients will be given inotorsin 20, and then 120 will be given LICA, the new one. And this is only for a short period of time, and then everybody will be getting the LICA molecule. And so this is currently, both of them are currently enrolling. Another trial is patisiran in cardiomyopathy. Remember, patisiran was already tested in hereditary neuropathy, and it's already available on the market. This one is in cardiomyopathy called Apollo B, and it's patisiran versus placebo, 1 year outcome of 6-minute walk test, as well as a bunch of secondary outcomes directed towards how people are doing, cardiac biomarkers, and then there's going to be an extension arm there. Vutrisiran, as I mentioned, remember, patisiran is an infusion. Vutrisiran will be a subcutaneous injection. And so coverage is different, but there are different aspects and benefits to each of them. This will be also a vutrisiran versus placebo in a cardiomyopathy trial. The nice thing is that about 30% or so is allowed of the participants will be allowed to use tafamidis. And so there is restrictions here, of course, on tafamidis use, but still, if you are on tafamidis and you get into the trial early, then you are allowed to continue that. And we will be measuring hard endpoints. You will always keep seeing this 30 months recurrent CV events. This is gonna be copied forward from every single trial, because we wanna be able to say that these trials resembled ATTRACT and they're showing benefit, for example, over tafamidis or similar to tafamidis, etc. The Trusuran Helios A, we also were participants of it, and it's already closed, of course. And some of you might have heard that Alanylam published the top-line results of the 9-month efficacy, which shows that it's effective and some promising data there. But we will wait until we see the publication as well as the 18 months efficacy. So this is not available for enrollment. This is in hereditary polyneuropathy or TTR neuropathy. And so the depleter mechanism, this is called PRX004. Many of you have heard about it. It's manufactured by Prothena. And what it does in simple terms, this is your tetramer. It's hiding a region there. Once it destabilized and becomes a monomer and deposits into the tissue, then that region essentially opens up. When it opens up, it allows us to go after it. And so Prothena the scientists designed this molecule that essentially is targeting that region. There was a phase 1 trial, and we're hoping to see a phase 2, maybe even a phase 3 from the get-go by the end of 2021, 2022. So stay tuned. This is important because the efficacy of stabilizers in NYHA class 3, there is efficacy. About 1 to 2 years, you're going to see many papers coming out on this from ATTRACT down the road. But NYHA class 4, for example, were excluded. So this is a very important point. The other thing is, we have looked at our own data. People say that we're over-diagnosing maybe TTR. That's not true. We are finding more and more patients with TTR, but we've looked at our data over the years, and there has not been an improvement in when the patients are presenting. Patients are still having significant clinical problem and significant disease when they come to our clinics. And so we still have a lot of work to do here. This is the NY006 Dr. Cheng had mentioned. I honestly don't know a lot about it because there are not many publications in that space. Phase 1 started in Europe, so we'll learn more about this. But it's a similar concept that there is a monoclonal antibody directed towards removing amyloid from the tissues, still early on. This is probably one of the most exciting things that is being developed. There's a lot of excitement, but you have to keep in mind, we are still super, super early on with this. This is Intellia's product where they use the CRISPR-Cas9 gene editing technology. I'm sure you've heard about this from before. I'm not going to discuss the platform or how it essentially works, but the bottom line is we wanted to go to the liver, edit the TTR gene to tell it you're not allowed to produce TTR anymore, or you're allowed to produce it, but in very, very minimal quantity. And so this is showing you in a mouse model as well as in a non-human primate model where we gave, not we, but they gave a dose here, and you can see how they knocked down the production of TTR. The model that did not get the treatment continued to have normal production of TTR while the reduction was impressive in those. And the key things to think about, this is now going to go to phase 1 in humans. It's not about only the efficacy. Efficacy might already be there. We need to learn more about, what is the safety, off-target effects, etc. They provide us with a lot of data on their website about, the safety in the animal models, but we'd love to see more human data. So stay tuned for the results of the phase 1 trial there. So in conclusion, this is an exciting time for amyloid patients, family members, and caregivers, as well as what we like to call ourselves maybe amyloidologists. There are commercial-only options, clinical trial only of both. So don't be discouraged and ask your physician or healthcare provider. We should exhaust all options prior to saying, well, sorry, we can't get you a medication. Go enroll in a placebo arm without standard of care therapies. I think in 2021, we have to be careful about that approach. The best strategy to treat ATTR remains to be determined. Meanwhile, the therapies we use should mirror those studies that are published. We cannot take somebody who was not enrolled in the patisiran trial or the inotorsen trial and say we want to utilize a medication. So we have to be careful about the distinction between hereditary trials and cardiomyopathy or wild type trials. And then partnerships are essential. This is a prime example of how partnerships work. Patients, patient advocacy groups such as ASG, physicians and academic researchers, as well as pharmaceutical companies and their representatives, we all should work together to advance the field. I'll stop here. A long list of acknowledgements, but truly it's all about the patients. It's from you and to you. Without you, we wouldn't have our programs or our trials or our science. And thanks to Muriel and everyone from ASG for all the work that you do.
Well, thank you so much. We have some time for some questions, so I'd like to get all of our physicians with their with their pictures up there. Okay, so definitely show their video, and we have some questions. But Dr. Masri, I have one for you right away because you know me, I have to ask the first question, and that is, you mentioned placebo, and we recently had a webinar. As a matter of fact, everyone can view our previous webinars, as I said, on our website and also on our YouTube channel, was specifically devoted to TTR trials. And they made a point of saying, the people that represented them, and we might have some pharmacists, some pharmacy people listening in on this, that in the United States, where there's a drug approved for the specific type of amyloidosis, they are allowed, let's say tafamidis is approved for cardiac, they are allowed to be on tafamidis for an Axia trial or for an Alnylam trial. And even the young lady from Eidos, which is a stabilizer, said that people were allowed to be on tafamidis for their trial, for their particular trial, if the trial was for people with cardiac involvement. Now you mentioned placebo. So where would that fit in there?
So if you look at the design of the studies, every study has a different design. When there will always be a placebo comparing the active new medication. But what we need to look at is, does the trial allow us to utilize tafamidis or even diflunisal in the setting where tafamidis is not present or not? And so that is one of the questions. Now, you mentioned AG10. AG10 did not allow tafamidis for the first 12 months. We enrolled in AG10 because it was before tafamidis was approved, and we've had patients who were not able to afford or get the tafamidis, which is fine. My point is, patients should think about this before they agree essentially to being in a study for a long period of time without exhausting all the options where they can get their treatment. You've mentioned some other trials. For example, I think I already showed it that some trials have limits on how many patients can be on the medication, on tafamidis in the background. For example, some of my patients who have advanced cardiac disease as well as neuro disease, I actually have been recommending that maybe we should get them commercial drug because then I can use a silencer and a stabilizer. Stabilizers were shown that they improve outcomes in cardiac disease, but they haven't been shown really much, at least with the 20 dose, to be very effective in neuro disease. And so we sometimes do a combination, silencer and a stabilizer. It might not be actually meaningful to do that, but at least at this point in time, we do not know. And this time if patients progress, we cannot buy that time back. So that's the point, is it's okay to be in a placebo only arm as long as the patients understand what that means and all the options have been exhausted before they can be in that arm, because these are long trials. These are not weeks essentially of therapy.
Okay, thank you. Let's take the first question. Cardiac MEMS, MEMS, I don't know if that's an acronym for something, has been transformational for me. How often are you using these implants? So let's take our cardiologist for this one.
Yeah, so I can answer that. So what CardioMEMS is, it's an implantable sensor about the size of a dime with sort of legs on the end of it. Essentially, it's implanted percutaneously. Typically, we go through the femoral vein. It goes into pulmonary artery and it's deployed. It's an outpatient procedure, so it's relatively non-invasive in the big scheme of things. The nice thing is at home, it transmits the pressures in the lungs consistently. And because of that, we can monitor the volume status for patients who have history of heart failure very, very closely. and titrate their diuretics frequently. There's also alarms where, for example, if the pressure goes above a certain threshold, then we know to essentially increase their diuretics. Right now, CardioMEMS is essentially approved for patients who have been hospitalized in the last year. And in patients with cardiac amyloid, for us, we use them for patients who have more than a single hospitalization. There are ongoing studies looking at this for patients without hospitalizations, with elevations in natriuretic peptides, with elevations in BNP, but that's not yet an approved indication. I think you're going to see more of this used moving forward. I think one of the interesting things is I actually have not seen many publications on this. And I had actually approached Abbott at one point about doing a study in amyloid patients using CardioMEMS. And it's something, you know, we're having ongoing discussions with. But I do agree for patients who do have hospitalizations for heart failure, it's extremely helpful because it, you know, you can keep patients optimized at all times.
Thank you. Well, we have you there. Is there danger in the long-term use of amiodarone, for example, years?
Yeah, that's a very good question. I think the challenge is with a lot of anti-arrhythmics, other anti-arrhythmics, they also have potential side effects. And when the heart isn't structurally normal, other anti-arrhythmics, for example, if you try using the class 1 agents, they can actually increase your risk for arrhythmias. And that's why we like amiodarone, because it's a relatively safe from a cardiac standpoint. In a sense, it doesn't really increase your risk of arrhythmias paradoxically. And it's very effective for all types of arrhythmias. It decreases atrial fibrillation, decreases SVT, decreases ventricular tachycardia. In terms of risk for long-term use, there definitely is a risk because it can, deposit and affect other organs. We monitor the thyroid, the lungs, because you can develop lung toxicity from it. You can get skin changes. So there are quite a few things that can happen with long-term use.
And the nerves.
And the nerves, yes.
Very rare side effect.
Yeah, our practice tends to be to get patients out of AFib, keep them in amiodarone for a period of time, and then if they're, if they don't have recurrent arrhythmias, we try to wean them off amiodarone because we try avoiding long-term use essentially.
Thank you, Dr. Distad. How often do you see nerve involvement in wild type, or is it almost exclusively in the hereditary form of TTR?
It's seen, depending on the study that you look at, it's seen in somewhere between 17% and 35% of patients with AL amyloid.
Not AL, I mean with wild type.
With wild type.
Okay.
Sorry.
That's okay. Would that be the peripheral neuropathy or the autonomic or both?
It is peripheral more than autonomic.
Okay. And well, let's ask Dr. Moshe-Lilie, do you also see that much in your practice?
Yes, unfortunately we do. It's, for us at least at OHSU, we see that more commonly than not.
Okay. So if that's the case, when do you think they'll allow the wild type with neuropathy to have a separate trial for these knockdown drugs such as the Axia drug and the Alnylam drug? No response to that?
Yeah, it's a good question. I think from a neurologist standpoint, there are different treatments for neuropathy, and it depends on what other features there are, because amyloidosis is often impacting somebody systemically. The decision on how to treat and with what is complicated, and where exactly it's going to come from, who's going to start a trial with that. The companies that you've heard listed today have been very active in this field, and I imagine they're the people that we would be looking to for future trials for other types of TTR or amyloidosis.
Thank you.
If I may add to
Sure.
that, so, like typically patients with wild type present with the cardiac disease. And so right now you have a lot of these trials ongoing for silencers in ATTR cardiomyopathy. So if they get approved for TTR cardiomyopathy, then we will generate a lot of clinical experience with them over time to also understand how they affect the nerve complication or the nerve complaints of patients.
Thank you. Well, Dr. Masri, while you're here, okay. You did go over briefly the Intellia information, and we know that it's in humans in the UK. But someone asked about any insight into this, or it also thus far for efforts to treat this organ. Okay, so basically concerned about it. I'm going to assume that this person has hereditary TTR. So do you have any insights into the Intellia?
So as I explained, it's still early on. We still don't even have a single, like they just started the phase 1 in humans. And so we really don't know. But the thing to look at is not the efficacy. The efficacy here is with gene editing is safety and off-target effects. Off-target effects mean, is there going to be anything else that we find besides knocking down just the TTR production?
Thank you. And we do want to remind people that the Intellia did a presentation for us at our last TTR meeting. So if you go to our website or go to our YouTube channel, you can watch that in its entirety. Oh, here's a question. Are patients, this is something we discussed, but are patients being accepted for patisiran, or this is while taking tafamidis? So this wouldn't be on clinical trials. So do you have patients that are on tafamidis and are also on patisiran? And I'll throw this out to everyone.
I will be starting that experience with somebody. I don't know if he's the one that asked the question.
It's a she, so.
Okay.
I mean, I can say I personally don't have any patients on. I know some other centers do in talking to them. I mean, the idea is a sequential knockdown. The idea is, with the patisiran, you're going to result in gene silence, or you're going to result in silencing of TTR production. The knockdown's going to be, typically in the 80% range. And then you're going to have some residual TTR, which tafamidis would stabilize. So theoretically, it would be more effective, but I have not seen much data on this. I mean, CardioTransform, a study that Dr. Masri covered, is actually allowing patients to be on tafamidis when they enroll into a study, and that half those patients are going to be getting a second generation like a compound, which is going to result in TTR knockdown. So we have a lot more data, I think, from the current studies.
So we have been doing this only in patients with significant mixed phenotype of both polyneuropathy and cardiomyopathy. And, I think we don't know the benefits of it, but in general, these patients that we've done it in them, they are getting tafamidis through the manufacturer. And so that, like the downside of tafamidis for us is financial typically. Very few side effects. There are some here and there, but nothing like too toxic or too aggressive. So the downside is not huge except for the financial downside. And so that's why we've been trying this, and we'll probably publish on this in the next year or two. We would have a lot of experience with it by then.
It's exciting to think that there, in AL amyloidosis, we have a four-part cocktail right now that our patients are taking. One's an infusion, one's a subcutaneous shot, the rest are pills. And it would be exciting to think that we might have a 2 or 3 or even 4-part cocktail for our TTR patients that, in the future. Okay, here's a question. Should amyloid patients take one of the COVID-19 injections? And if so, which one should be taken? We'll ask all the doctors this. Let everybody put in their 2 cents on COVID-19, Pfizer versus Moderna versus the new Johnson & Johnson. So take it away.
I would certainly advocate for individuals getting the COVID vaccine. I think that in neurology outcomes, we've seen some significant problems with people that have had the COVID infection, not the vaccine. And I would strongly advocate for that. It's early as far as seeing outcomes from the vaccination, but I would say in people that, many people in healthcare have gotten it, we've had very good outcomes and not problems with the vaccination. I think also a lot of neurological diseases can get worse with infection, and certainly COVID with comorbidities. If you get that infection, I would be very concerned. I think the answer to the question of do some of the treatments alter your immune response, we don't have a very good answer to it, but I would say the experts are confident that your body's going to launch a good immune response to the vaccination.
Anyone else want to put in their 2 cents there? All right, well, Dr. Distad, since we have you, if you could unmute for 1 more second. People are always saying, well, I'm afraid of the Johnson & Johnson because it's only 1 shot, and 2 shots sounds like it would be better. So what is your opinion on that?
As far as efficacy, I think that there was the numbers that they had, the number of patients that they had in the different trials varies. The longer we go on, the more information we have about effects of them. The efficacy in the first 2, Moderna and Pfizer, was very high. These are kind of created numbers. These aren't our standard blinded randomized controlled trials. I don't know as much about the Johnson & Johnson. I did get information from some of our University of Washington experts about the 2 other agents that involve mRNA. I think they're all fairly effective. I wouldn't say we have enough data to choose one over the other. And I think the effectiveness has been shown in each one of them.
Thank you. Yeah, I'm always hitting on our Mayo physicians to answer this question when someone asks it, and they always say, take the first one offered. So the most important thing is to get the vaccine quickly. So here's another question. I am currently on patisiran and would like to know if or when the 3-week infusion may increase to a longer in between. In other words, he wants a gap in between 3 weeks. So Dr. Distad will ask you, and then we'll ask Dr. Moshe-Lilie. What is your opinion of gapping these treatments? Do you think that you'll need a clinical trial to do that, or do you think you can kind of make a little guess on what to do now? You're on mute. There you go.
That's because I was muting my cat. We don't know, and this is true in some other treatments as well. The data, and maybe Dr. Chen could speak better to this, as far as how often do we need to dose it? How long is it expected to last? Where did we get this number of 3 weeks? And I would say we don't know. And the downside is that the benefits are seen months, even years out. And so I think I would be hesitant to try to increase an interval without that knowledge. On the other hand, with a newer agent whose dosing will be easier, it is likely that there will be other agents that are going to replace the patisiran over time. So I'm sorry, I know that's not a great answer.
But it's an answer. Dr. Moshe-Lilie?
Yeah, I totally agree with Dr. Distad. I'm not a pharmacist, but I would say that, it really depends on the basically blood concentrations and whether or not expanding that infusion will cause disruption in the concentrations and the steady state of the medication and causing people to flare or have more symptoms in between.
And Dr. Chen?
Sorry, I think you probably want the Dr. Chen, but I was just going to add, I agree with them that with these newer generation drugs, the frequency is going to extend out. I mean, even, for example, with The choriotransferrin, for example, sub-Q injections once every 4 weeks. So I think most likely, my guess is you're not going to be seeing an extension of the intervals for first generation drugs, but rather replacing that drug with a newer generation drug.
Okay, what about our pharmacist, Dr. Chen?
You know, these agents are all, when they first design, they do a lot of pharmacokinetic studies. And then based on, you know, like the peak and trough and how well the drug into your system and the site of action, they kind of come together with a number of frequency. And usually that's how it came about. And obviously the real world experience might be different, but because the way the study was designed, usually we go with the frequency, you know, it was designed. So that's just kind of the way it is. And the newer generation, like patisiran, will be much longer, will be also sub-Q injection. So if that's effective, then, you know, it'll be a better option later.
Okay, thank you. Here's someone, they actually sent in a text. I've read about patients reducing or eliminated the pre-drugs. Evidently, there are some pre-treatments that are taken along with the inotersen drug and also the Onpattro drug. And they want to know if anyone can speak to eliminating them. Perhaps you can tell us what they are and then talk about eliminating them. So let's bring our neurologist in on this again. Dr. Distad?
My disclosure, I am just starting patisiran for the first time. I have not used it in anybody else. On reviewing the medication pre-treatment, there's a steroid dexamethasone, and the initial amount is pretty significant, 10 milligrams. There's Benadryl, and then there's Tylenol. These all minimize infusion reactions, which is one of the problems with patisiran. Over time, these can be dropped down depending on what types of reactions people have, but I can't speak to experience with it.
Okay, and Dr. Moshe-Lilie, anything to add to that?
I would say similarly that's the case, that it really solely to decrease side effects from the infusions. We haven't done any studies, at least from our end in neurology, but I do know from other clinical trials published that there have been issues with patisiran, and that's the role of those pre-medications.
Okay.
So if I can jump in.
Sure.
So, you know, the whole point of the pre-medication is to reduce the side effect, as everyone has said. And, you know, the first couple of times you can use the steroids, and then after that, you can actually try, because these are just going to be annoying and, you know, problematic side effects, but they go away essentially. And especially if you're at an infusion center and you're not, you know, at home infusion, we have done this in the past where we ask the infusion center to reduce the dose of the steroids given. And I know people on the East Coast have given it to patients with severe cardiomyopathy without steroids after the first couple of doses there, and they've been doing well. For inotersen, we don't pre-treat. We only have one patient who always continues to develop systemic reaction to the inotersen injection, gets hypotensive and having symptoms, but he doesn't want to switch to a different medication. So we continue to pre-treat that specific patient before inotersen, but others we do not.
Okay, thank you. And then we have patient concerned their neuropathy is continuing even though they're on treatment. They've been on treatment for 14 months. Their neuropathy pain has not changed and is getting worse. They're taking Lyrica. They want to know if there's any alternatives, and they want to know, has anyone prescribed mindfulness training from professional programs? And what can this person expect to see over the next year or so for help with neuropathy pain? So,
yeah, I can, there are certainly other options. I listed a number of medications, and sometimes using those in combination can be effective. Sometimes a low dose of one and a higher dose of another. So it's kind of, if you're talking about Lyrica, the pregabalin, gradually increasing it to maximum response without producing significant side effects. We have, at University of Washington, we have a fantastic pain clinic. And with that, they do work with people in accessing training for mindfulness. There's a psychologist, and then they also have trials that I don't prescribed, but different medication trials and different approaches. Sometimes injections, not so effective for more of a global neuropathy. But yeah, absolutely. Those are great other ways to look at trying to get at controlling the pain.
Great. Okay, we're done with our questions. Of course, we went over time, but anyone who's ever been to one of our webinars knows that that's not a surprise for anybody. Okay, but we kept this down from 4 hours, and I'm very proud of our physicians and everyone for doing that. Before we go, okay, I do want to mention we have a mental health webinar coming up next month. We'll be letting you all know about that. We're bringing in psychiatrists, psychologists, social worker, someone from NAMI, and so if you're depressed, if you're anxious, I mean, COVID I think brings that to everybody a little bit, but this is beyond COVID. This is just, you know, being a patient frustrated with your caregiver, a caregiver frustrated with their patient. We know that all marriages aren't perfect. So whatever the issue is that you would think falls under the mental health umbrella, please join us for that webinar. We, again, will be telling you more about it soon. And why don't we see if each of our guests, we really appreciate it. We know you've got other things to do on Saturday, and this is certainly above and beyond for all of you. And yeah, I don't have a doctor that would give me even a half an hour on a Saturday. So we really appreciate this. So if you have a couple of parting words for everyone, and Dr. Distad, since you're on the screen, we'll let you start, and then we'll just go through all of them.
I'm very excited about getting into the field of amyloid neuropathy. I've treated neuropathy for decades, and I'm always looking forward to options and new ideas, and excited about these treatment trials to help patients work with neuropathy and do what we can to get things better. And there's a lot of great people in the field and great minds working on this. So much more to come in the future.
Thank you. I think we can see about the people in the field and the great minds. It's pretty awesome. Okay, Dr. Mooney, how about you next?
Hi, everyone. Thank you for inviting me to speak here. It's been a pleasure. I am looking forward to helping get the word out. And so just making sure any of your friends looking for symptoms, letting them know to ask their doctors. I think we need to start screening people more. So I'm looking forward to this group expanding and helping more people.
Super. And Dr. Cheng?
Yeah, no, I think this was a great session. I wanted to thank all the attendees for coming and your interest, because you guys are kind of what makes this field so great. I think, you know, one thing that we're working on is strongly in education in terms of working with the different community centers throughout Washington State. And I think, you know, moving forward, hopefully that'll, you know, those efforts will continue. I did also want to put a plug in, if Muriel's okay with it, for, you know, we are developing an amyloid working group as part of the International Cardio-Oncology Society. So we are going to be hoping to put together some materials and webinars through that. And I think Muriel's working with us on that through Dan Lenahan right now. So thank you.
Thank you. And who wants to be next? Say a few words.
I'll just pop in. I'm actually taking over for Dr. Libby. My name is Dr. Lee. I'm one of the hematologist oncologists at the University of Washington, and he had to step out, so I filled in for the last part. But, you know, as someone who treats the light chain amyloidosis type, I think, you know, this educational session for myself and for our patients was really great. I would just encourage all patients, especially when you have a diagnosis like this that is rare, to really not be afraid to be an advocate for yourself. Come to these, you know, centers where we see patients more frequently, ask the questions, ask for further testing, make sure you have the right diagnosis, and make sure you have the right people on your team. There's a lot of things that are exciting happening in the light chain amyloidosis world and also in the TTR world. So hopefully we can all work together and, you know, for our patients. So, yeah.
Thank you, Dr. Lee. And yes, I didn't mention that, but Dr. Libby had to leave a little bit early, but thank you for sitting in for him. Okay, and do any of our other physicians or guests wish to say a few parting words? Oh, okay, well, in that case, we will, Dr. Masri, let's.
No, I was just gonna say thank you all, and thank you, Muriel, and everybody at ASG. Thanks to our patients and everyone from our panelists for actually taking the time on a Saturday to join us. It's been a pleasure, and looking forward to seeing you in other webinars.
Thank you. And I think everyone watching this, if none of you are their physicians, they're very jealous, and you'll probably have some new patients signing up next week. Thank you, everyone.
Thank you, Muriel.
Bye-bye.
Thank you.